हाँ बोल. हाँ. झालं का सुरू? थांबा बोल. हाँ दिसतंय दिसतंय दिसतंय. येस. हाँ बोल. The meeting is being already started streaming, so uh, we can just mute ourselves, and if you want you can stop your video because we'll go live at 4 o'clock, but the streaming has already been started.
Hello. Hello, can you all hear me?
Yeah, yes, sir. We can hear you.
Okay, because I'm sorry, it's a new laptop, so I'm getting a little confused. My screen also didn't open properly.
Okay. We are already live, so we'll start at 4 o'clock.
So can I just do my screen sharing once, please?
Sure,
Because,
sir.
like I said, it's a new laptop. I don't know. One
Please,
second.
please.
I'm just gonna try. One sec. My video is only not on. One sec. How do I?
Hello. Yes,
Yeah,
yes,
yeah,
sir.
yeah. Give me a second. Give me a second. Okay.
Yeah, yes, sir. We can hear
Oh,
you.
okay. Because I'm sorry, it's a new laptop, so I'm getting a little confused. My
Hello.
Hi, Dheeraj.
Hi, Priya.
Yeah, hi. I'm back again.
Yes,
Give
sir.
me 1 second now. Let me see. Okay, because it's keeping on asking for permissions. This is the problem. And then I have to keep restarting. Okay, fine. That's good. Hi. Okay, just let me try my screen sharing once because otherwise I'll have to just log on with my old laptop. Okay. So far, so good. And okay. Can this be seen now as a PPT?
Yes, yes, it can be seen.
As a PPT, right? Okay, fine. Okay. So then we are good.
Pradeep, I can't pick up the phone. You're calling me.
Okay, I
Hello?
can't see. Yeah,
So,
yeah. Give me 1 second. I can't do. Is it still sharing?
yeah, it's sharing. You can just
Okay,
stop sharing.
1 second. 1 second. I found the button. Sorry, I couldn't find the stop share button.
Okay.
I'm damn sorry.
So
Pradeep,
it's,
yes,
yeah.
it's 4. We have to start.
That's 4 o'clock, and this is the series of the pre-WIROC webinar. So, Dheeraj, the Dr. Dheeraj is the organizing secretary for WIROC 2024. So, before I hand over the proceeding to Dr. Kshitij Chaudhary, who is the convener for this WIROC, and Dr. Samir Darvi, who is the chairperson for this particular webinar, I would hand over the proceeding to Dr. Dheeraj, who is the organizing secretary for WIROC 2024.
Thank you, Dr. Pradeep. Thank you, all the esteemed faculties, Dr. Kshitij, Dr. Samir Dalvi, and all my other esteemed faculties. So, good afternoon, everybody. Good afternoon, all the delegates attending this pre-WIROC webinar series. So, today's topic is on osteoporotic fractures in spine, which is a very crucial topic in spine. I encourage you all attendees here to register for WIROC 2024, which is to be held in Mumbai from 20th to 22nd December in JW Marriott. This WIROC is just a starter or trailer for getting ready for the four-course meal in academics at WIROC. We look forward to seeing you all and get this enriching experience of knowledge, collaboration, and innovation. Thank you all for joining this spine session. And over to Dr. Kshitij Chaudhary.
Kshitij, you're muted, so I'll take over. So let's start this webinar. Kshitij, you're muted, so nobody can hear you. Anyway, so this webinar is actually, I'm supposed to be the chairperson, and but it's Kshitij baby actually. So we've got 4 speakers first, and then we have case discussions. And the talks are, I will just tell you what they are. The first is searching for the secondary causes of osteoporosis by Dr. Balki, who I will explain, introduce in a minute. But we also have a radiologist with us. We have Ankita, who's going to tell us how to differentiate benign versus malignant vertebral compression fractures. We're going to have Amit Sharma tell us about the conservative treatment and the risk factors for failure of this conservative treatment. And then I'm going to talk about something about interventional treatments for osteoporotic fractures. And after that, we'll have typical Bombay Orthopedic Society style case presentations with interactions. So I will invite our first speaker, Dr. Balkrishna. Dr. Balkrishna is one of the most senior rheumatologists actually in the country. And he has studied his rheumatology not only in India and in Hinduja with Dr. V.R. Joshi, who again everybody knows, but he was also in the UK at Bath at one of the top rheumatology centers. And he's by far the most sensible voice of reason in the field of rheumatology. And so I introduce Dr. Balkrishna. If you may start your talk.
Thank you very much, Samir, and also Kshitij and the Bombay Orthopedic Society. I would like to share my slides. Can you see my slides now? Yes?
Yeah, we are waiting for your first slide.
Yeah.
Yes, now it has come. And I request everyone else to mute their microphones at this point.
Right. So I got interested in osteoporosis in Bath. Like Samir said, that's where I trained. And that was the first place where densitometry machines came to the UK. And very funnily, there was a professor of bone densitometry there, nowhere else. And so I learned my osteoporosis and how to read DEXA scans, etc. with them. The topic given to me is secondary osteoporosis, which is very important. And I'm going to go through these following things. One, what are the causes of secondary osteoporosis? What is the prevalence? When do we look for it? What investigations do we do? How do we go about treating them and how to monitor? It's 15 minutes, so I'll be able to only give you a summary of how to do all this because it's quite a vast topic, especially the secondary causes with all the systems being involved as a cause of osteoporosis. We'll go one by one. So if you look at the secondary causes, so the three, four main secondary causes are, I'm sorry about this. One is endocrine. Second would be gastrointestinal, hematological, drugs, rheumatological, and miscellaneous. It's obvious that I won't be able to go through all of this because we'll not be able to finish the talk in 15 minutes. I've just underlined the ones that are very important. Hypogonadism, especially in males. We know about postmenopausal osteoporosis in ladies, but hypogonadism is not uncommon in men with osteoporosis. We do get hyperparathyroidism once in a while. I have underlined hyperthyroidism because both hypo and hyper can cause osteoporosis and one needs to be conversant with it. Cushing's syndrome is important. Gastrointestinal causes we tend to miss, especially the ones with malabsorption. Hematological causes all of us go through once in a while. We do get a multiple myeloma, especially with fractures, especially with vertebral fractures. And I'm sure spine surgeons are the ones who have dealt with quite a few of them, along with their oncology and hematology counterparts. I'm not going into the drugs part where steroids would be a separate topic in itself, maybe a half-an-hour topic. So I'm not going to go into the details of that. Rheumatoid arthritis and many other arthritic diseases are well-known causes of osteoporosis, mainly because of two things. The inflammation itself weakens the bone by many, many methods. The pathogenic mechanism are quite few. And the arthritis itself leads to a reduction in mobility of these patients and reduced weight bearing on the joints and reduced exposure to the sun. So many other, and the drugs, the kind of drugs that are used, everything put together, rheumatoid arthritis and many other arthritic diseases are very well-known causes of secondary osteoporosis. Vitamin D deficiency, I don't have to teach Greek to people living there. This is something so common that we all see it. Sometimes we over-treat it too. That also is something that we are seeing over a period of time. So these are the secondary causes of osteoporosis. But if you look at the prevalence, what is the prevalence of a secondary osteoporosis in a patient with osteoporosis or osteoporotic fracture who's come to you? It's seen in half of premenopausal females. So that's not a small number. Half of premenopausal females having secondary osteoporosis. And up to 2/3 of men, almost 40% of men have a secondary etiology for osteoporosis. Apart from hypogonadism, the other things that you need to look for in men. And in postmenopausal women, which is where we see the maximum number of patients with and without fractures, 30% of postmenopausal women have secondary osteoporosis. So in a way, a significant proportion of patients with osteoporosis who come to us may be having a secondary cause, and it's imperative that we check for them and treat them too, in addition to treating all the other manifestations of osteoporosis. So when to look for it, and that's exactly what I said. By and large, in all patients with osteoporosis who come to you, it may be worthwhile doing at least a bit. You're damn sure that this is just postmenopausal osteoporosis, nothing is happening, but still it might be worthwhile to do a few simple tests just to make sure that you have not messed out the common secondary causes. But when will I look especially for a secondary osteoporosis? The younger the patient. So supposing this is a premenopausal lady, somewhere in the 40s, who's still having normal menses, and she's had osteoporosis. Now that should make me search for the cause of osteoporosis now. The second and most important pointer is painful osteoporosis. If somebody with osteoporosis has pain, because by and large, osteoporosis is a painless disease until a fracture occurs. But if somebody has a significantly painful osteoporosis, tender everywhere, this is the group in whom you would think of secondary causes. We know about osteomalacia and vitamin D deficiency in our country. Hyperparathyroidism causes painful secondary osteoporosis. Multiple myeloma at a later age causes secondary osteoporosis. Bone secondaries will also be a cause for secondary osteoporosis. So the third group, which I've written here, is for any DEXA scan that you see, by and large, the T and Z scores match. If somebody has a T score of -2, but a Z score of -4, again, your antenna should go up that for that particular age, he does have T score. Osteoporosis is there when compared to a 30-year-old, but in comparison to his own peers, the T score is very, very low. So therefore, there could be a secondary cause on top of whatever you're seeing. So these are the ones in whom you would again search for a secondary cause. History and clinical examination probably is much more important in secondary osteoporosis than in primary. So I'm just going through a few simple cases which we all of us see just to give us a feel of how these are. This is a 36-year-old lady, again a young lady, possibly premenopausal, who came to us with very painful joints and proximal muscle weakness, the DEXA of -3, and she was very tender everywhere. So a simple X-ray of the pelvis showed us that she had the looser zones, bilateral symmetrical on either side, and then also the pelvis also showed some deformities which were typical for osteoporosis. So vitamin D deficiency, calcium abnormalities, and other causes of osteomalacic osteoporosis is also very, very important. Although here, actually, it's more of osteomalacia than pure and simple osteoporosis. But if you do a bone density scan, they might fall into the osteopenic or even the osteoporotic range. A 55-year-old lady with painful osteoporosis again. All laboratory tests were normal except for low phosphorus and intermittent hypercalcemia. You can see the abnormalities there on the X-ray, and the one to your right, the lower end of the arm, you can see a large osteolytic with an osteosclerotic lesion, which turned out to be a Brown's tumor. And eventually a parathyroid scan was done and a large parathyroid adenoma was seen. And then it was excised, and then the patient improved over a period of time. So 70-year-old male again, severe back pain, treated as a probable osteoporosis Cox. X-ray itself showed multiple fractures. The MRI on the right side has shown fractures in this patient. And then when we did the bone, we also complained of pain everywhere. And since the age was going on, X-rays of the skull and X-rays of the other areas, a skeletogram was done. And that showed multiple punched out areas. And eventually it turned out to be multiple myeloma, which was treated and the patient improved. A 42-year-old male, severe backache, multiple compression fractures in the dorsolateral spine, has severe osteoporosis, has hypertension, diabetes, truncal obesity, and a T-score of -4 was referred from the orthopedic side when I joined this institute somewhere in 2001. And this was the MRI showing old and new fractures which were evident in the spine, multiple fractures as was expected. And clinical examination showed a very Cushingoid gentleman with striae. And this eventually turned out to be due to a malignancy, a tumor, and he had Cushing's syndrome. So when that was taken care of, his osteoporosis was slowly improved over a period of time. So the cases like this are many. A 56-year-old patient with diabetes and hypertension for a long period of time, also had chronic kidney disease, CKD, for 10 years, and was conservatively managed for most of the period and consulted us again for very severe back pain. And here you can see on the X-ray that he had a rugger jersey spine, which is a term given to the kind of T-shirts that we're using in rugby in the UK. But sclerosis followed by penia, the sclerosis and penia alternate and giving you that picture. The problem in kidney patients is that the bone problem can have multiple pathogenic mechanisms. It is just not osteoporosis. Osteomalacia is also common. Secondary hyperparathyroidism, and at times tertiary hyperparathyroidism also occurs. And they also get brown tumors, osteitis fibrosa cystica. So it's a little tricky when you have to treat these people. So what investigations do we do? So in a barn door osteoporotic who does not have any other clinical features to really suggest a secondary osteoporosis, you will do the following, which I put on this slide. You will have CBC, ESR, a bone profile, kidney function, liver function, vitamin D, obviously you'll do it. And normally we would do vitamin D along with PTH because they are counter-regulatory hormones. And it's very easy to assess one when you know the other. TSH, yes, because both hyper and hypoparathyroidism are not uncommon in the general community. And PTH, especially when the bones are. So if the ESR is elevated, then you would do other things to make sure, especially if the age group is okay, you would do other things. So these are some things that we would do in any osteoporotic. Any osteoporotic, it's mandatory to at least do these things. But in those in whom you have clinical suspicion of other disorders which could be secondary and causing the osteoporosis, you would do serum protein electrophoresis, urinary Benz-Jones proteins. In males, you would do serum testosterone and sex hormone binding globulin. You would do IgA tissue transglutaminase if you're thinking of malabsorption in somebody who's been having loose motions, losing weight, and has multiple deficiencies that are evident clinically. And in Cushing's, that like one of the patients that I presented, you would do the steroid. So how to treat secondary osteoporosis? It's very important to know that you have to treat the underlying cause. That's the foremost in this case, because that's the one that's going to give back the bone strength to the patient. So if it is Cushing's, treat the Cushing's. If it is myeloma, treat the myeloma. Rheumatoid, treat the inflammation better and get the patient to move better. Steroids, stop the steroids if possible. That sort of a thing. So the secondary cause, which is identified as a cause of osteoporosis, has to be taken care of. Specific treatment for osteoporosis will also be needed, especially in those who have the usual risk factors for osteoporosis. If this patient is postmenopausal, if this postmenopausal lady gives a family history of fracture in mother or father with hip, especially older aged men, if there are other prevalent risk fractures, no dairy intake, excessive alcohol intake, fragility fracture is already present. So you would also be err on the side of caution. And apart from treating the secondary cause, you would probably go ahead and treat chronic disease which impacts the bone. Bisphosphonates remain the best option in this group, except when there is renal impairment where injection denosumab is preferred. Do not give bisphosphonates before replenishing calcium and vitamin D because it worsens the osteomalacia if evident. So how to monitor depends on the underlying condition. Most reversible endocrine condition, you would probably repeat a DEXA scan in a normal primary postmenopausal osteoporosis in 18 to 24 months. But in secondary osteoporosis, since the bone becomes better much faster, you may be justified in repeating a DEXA scan in about a year and showing the difference. Improvement and worsening to be assessed comparing the actual BMD values and not the T-scores. And so this is the last slide. To conclude, I would probably think of secondary osteoporosis in all patients, especially in the young, the painful and very severe osteoporotic, wherein the Z scores far outlie what you would expect for the T scores. Treat the cause. That's the only way to treat the osteoporosis, secondary osteoporosis. But apart from that, if there are risk factors for the usual osteoporosis that we normally see, then treat them with anti-osteoporotic medications too. Bisphosphonates would be the drug of choice for many, and especially the renal ones, be a little careful with any other drug other than denosumab. And when improvement in the DEXA scan is much faster than in primary osteoporosis, so therefore doing a DEXA scan a little earlier than otherwise is not a bad idea. I thank you all for a very patient hearing.
Thank you very much. Can you hear me?
Yeah, did I finish on time?
Yes, yes. Thank you very much. So wonderful talk,
Perfect.
enlightening. Hello. Yeah. So we'll take questions for Dr. Balakrishnan. So any questions from the panelists? I think we have some people joined on the Zoom. Let me ask sir a question. You said those mandatory tests, you included liver function test. Why would you do that?
Basically for two reasons. One is that the protein production occurs, many proteins get produced in the liver. That's one. Secondly, vitamin D, as you know, the 7-dehydrocholecalciferol that is formed in the skin gets converted to 25-hydroxy-D in the liver and then goes to the kidney to form 125. So in liver problems, the 25-hydroxylation does not occur well. So there are a lot of vitamin D related problems. What you need to realize is that when vitamin D goes down, PTH goes up a little. They may still be in the normal values, right? But that little increase in PTH in that particular person is enough for bone loss to occur. He is not yet gone into the secondary hyperparathyroid range. It might not go into 140s, 150s. It might have just gone up from somewhere around 30 to just 50. But that increase in 20 for that particular person is enough for him to start losing bones. So you might become osteoporotic over a period of time. So vitamin D causes the bone loss in more than one way. So apart from osteomalacia, the early stages, the increase in PTH, which is the counter-regulatory hormone, leads to bone loss.
Kshitij, may I?
Yeah.
In the patient with the renal problems, when you are treating them, is denosumab allowed or not?
Yes. So you will first, what you will have to do is you will have to get the help of an endocrine person. We also do, because we need to find out which part of these three things are more important in that particular person. Is it just osteoporosis? Is it osteomalacia? What is happening? Secondary hyperparathyroidism also. Whatever is happening, that metabolic thing has to be corrected. And once that is corrected, the only drug which is safe when creatinine is high and problems are occurring is denosumab. PTH is not to be given. Not teriparatide. No, 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 no. Neither teriparatide nor bisphosphonates are useful in that group. Denosumab is the drug of choice.
Okay.
And then what about these measurements of urinary 24-hour like calcium levels? When do you do those?
That's when you're thinking of tubular dysfunction, you're thinking of osteogenic or osteomalacia due to malignancies, many other things. So normally you don't do all that. You don't know to do it routinely. No. Phosphorus, calcium, albumin, PTH, vitamin D, these are the usual, apart from your liver and kidney and other things which you do normally.
All right. So we'll move on to the next speaker. Thank you very much, Dr. Balakrishnan. So
thank you all. Thank you all for having me.
Thank you, Dr. Balki.
Thank you, Samir. Have a good time. Bye.
So the next speaker is Dr. Ankita Ahuja, who is the musculoskeletal radiologist with InnoVision. She has a special interest in spine imaging as well. And fortunately, she's associated with the Hinduja hospitals with us. So we use her expertise very frequently at CAR. And she is going to speak on the differentiation between benign versus malignant fractures in the spine. Over to you, Ankita.
Thank you. Thank you so much, Kshitij. I hope the voice is clear.
Yes.
Yeah. Thank you. Thank you, Dr. Kshitij and Dr. Sameer Dalvi for the invitation and the entire team. Such a pleasure to be here and to listen to you all also. So gives us more insight. So thank you once again. So what we are going to discuss in next 10 to 15 minutes is how we differentiate benign from malignant vertebral fractures. Before I go into that, I just want you all to know that what a normal spinal marrow should look like. So let's start with one slide just on the normal spinal marrow. Whenever you're looking at the vertebral bodies or the spinal marrow, the sequences of choice which you want to see are T1 weighted images and your stir weighted images. So this is very important. Mostly what we require is T2 weighted images, but when we are looking at marrow, we focus on T1 and stir weighted images. That's the key. So if you look on T1, you identify that this is T1 because the CSF is dark. Then what you start to see that your vertebral marrow is bright, mostly because of the fatty component within, and it should be always darker than the disc. So you compare your marrow with the disc. So if this marrow is always brighter than the disc, if you see this marrow becoming same as the disc or darker than the disc, then you know that there is something wrong going on with the marrow. Then this is your stir weighted image, in which because the fat is suppressed, so the marrow has become dark like any other joint. So the marrow within the vertebral body is appearing dark, and you see fluid over here, and rest on marrow looks dark. And so if you see anything bright on stir, that's a clue that there is something going on in that vertebra. So this is something very basic which we should know before we dive into the details. So summing up that, normal marrow always brighter than the disc on T1 weighted images. If it looks darker, then you are worried. So T1 is your best friend. Then moving on to the topic, that is benign fracture versus malignant fracture. So benign fracture, what do we mean by benign fracture? We are basically talking about osteoporotic fracture. So as we all understand, the bone is already weak. We put a little load and the bone cracks. However, in malignant fracture, there are some other cells which are coming and replacing the normal marrow. So the normal bone is again getting weaker, but not that kind of loss of integrity. And as a result of replacement, the bone collapses. So let's see what we are. So what is the investigation which you usually do? You would obviously do a radiographs, but the investigation which really helps you to differentiate is your MRI. What do you want to look on an MRI? So there are a few things which we are going to look at. We are going to look at if we can pick up a fracture line, vertebral body contour, marrow signal, involvement of the posterior elements, soft tissue component, and multiplicity. So these are the 6 key things which you should look for always. So let's start with the cases and each and every point. So if you see, this is your stir weighted image, T1 weighted image, and another coronal stir weighted image. Here, do you see this fluid cleft over here? Can you see this discrete bright cleft on this fluid with some marrow edema, which is looking dark on T1 weighted images? So if you see this discrete fracture line or the fluid cleft, you are very sure that you're dealing with something which is an osteoporotic compression fracture. Then moving on to the next point, which is the most interesting and actually the most helpful point, which is to look at the vertebral body contour. To explain this, I have learned it from my mentor, Dr. Aditya, a very beautiful example of a cardboard box. So just imagine your vertebral body is like a cardboard box and it's just discrete and sitting well, like this is one. But if it is osteoporotic or it's weak and you put a pressure, it just cracks down with blunting on both the ends. So you put some pressure and starts to wedge. So you resultantly you develop these wedging on all the corners, which is called as the retropulsion, which is most common posterior superiorly. So that is a clue that you're dealing with something which is benign or osteoporotic. Then just imagine the vertebral body is filled with something like a booster or something which is light, but it is filling. If you try to press it, it will just bulge out because there is something already too much inside, so it has to just bulge out. So you start to see this convexities, more commonly seen posteriorly. So you see posterior convexities to develop, which is a clue that this is malignant. This is one finding which really helps you in very difficult situations. So let's see examples. You can see there are quite a few collapses which you can see over here. Let's start with this one collapse. So can you see this vertebra is almost completely collapsed? And when you start to see, there is this fragment in the anterior superior as well as posterior superior segment. But the posterior margin is still concave. It has not become convex. So this is a osteoporotic fracture, with this being the posterior superior retropulse fragment. If we see again this, so this is again got compressed, the margin is still convex, and there is not much of retropulsion as such which has still happened. But overall, the picture fits into an osteoporotic compression fracture. As against this example, so let's see this. So you see bright marrow signal with a little darker marrow signal in these vertebra. And you try to see the posterior margin. Can you see how convex the posterior margin has got? So these vertebrae have got collapsed, but the posterior margin has become convex. So this is the convexity which is seen posteriorly. So this is your, what would you call this as? This is like classic, which you see with malignant osteoporotic fractures. So you should always try to look for this finding, which is really helpful. Moving on to the next feature which we need to look for is the marrow signal. So with respect to the marrow signal, we are trying to, again, if it is a benign, because there is a fracture, so there is going to be marrow edema. So there is some edema will there. But in addition, you will figure out there are some fat spared areas because it's just marrow edema. Marrow has not been infiltrated. So you will see fat spared areas within the vertebral bodies. However, in malignant, because there is something which is infiltrating the normal marrow. So once you try to look on T1 weighted images, the marrow would be replaced. It will look completely dark if it is a diffuse infiltration, or if it's very focal, it will look very rounded, sitting in a vertebral body. Again, let's see examples. So we see a vertebral body collapse over here. We see the posterior convex margin. So from the previous 2 points, only we are already starting to think that this is a malignant fracture, right? But then in addition, we try to see the marrow. So if you look for the marrow, it is completely replaced. You do not see any fat spared area over here. So this is a malignant vertebral collapse. There is another myth which is very well defined and rounded, which is again giving you a clue that this is a case of metastasis. And luckily in this case, we could find a renal cell carcinoma over here. So this is a definite case of malignant compression fracture. Moving on to this case. So again, you see multiple compression fractures over here in this, and this vertebra. So I want you to bring your notice to this vertebra because this creates a little confusion. So I see a little fluid cleft over here. So that points to me that I should think of a benign or an osteoporotic fracture. But when I look at the posterior margin, it looks slightly convex, which creates a little confusion because that point is very important. But if you see in addition, this posterior marrow is still fatty. This is still bright on T1. So this is still fatty marrow. Right? So if you're seeing the fatty marrow, then you know that you're dealing with osteoporotic along with this fluid cleft which you have over here. So this is nothing but your osteoporotic fracture. Moving on to the next point, that is involvement of the posterior elements. So in benign fracture, if at all, there would be little edema in the posterior elements, that to the pedicles, but they are not really involved. So on T1 weighted images, they would look normal. However, in malignant, because the pathology only starts, the malignant cells enter through the Bateson's plexus, so the posterior vertebrae are more often affected, and from there they can go to the pedicles and posteriorly. So the posterior element involvement is very common. So again, let's see examples. So this is a case where I see a compression fracture, but I see posterior superior retropulsion and some spared fatty marrow. So I know from the previous features itself that I think this is a osteoporotic or a compression fracture, but not malignant. But then I go on stir weighted images and I see some edema in the posterior elements. I come back to my T1 weighted images and check that this is not dark. This is like a normal marrow. So this is just edema from this fracture which has gone into the posterior elements, and I should not be worried about it. And all my rules are falling into place. So this is osteoporotic compression fracture. Seeing another example following the previous rules, vertebral body compression, posterior convexity, no normal marrow seen, completely infiltrated. I'm pretty sure that this is a malignant fracture, malignant compression. But then I again go down to the posterior elements on the either side. I see stir bright and I also see the T1 darkness. So I know that the posterior elements are also involved, and there is no doubt about it that this is a case of malignant collapse with the involvement of the posterior elements. Similarly, in this case, you know, collapse with posterior convexity, collapse with evolving posterior convexity. But in addition, you see big involvement of the posterior elements, the spinous process, which adds on to your confidence that this is going to be your malignant vertebral collapse. Moving on to the last point, that is the soft tissue component. So when we are looking at soft tissue component, again with benign, usually you will not have a very significant soft tissue component, but sometimes hematoma can be there. And also if you imagine that there is an osteoporotic compression fracture, so the vertebra is collapsing like this. So you might see a little diffuse kind of an edema around the vertebra, which is perfectly normal. However, malignant soft tissue components, you will see usually very focal soft tissue component. It will be very hypo-intense on all the sequences, like solid mass kind. And if you are lucky enough that you get a situation to give contrast, and even in difficult situations, ideally, if you feel it's a difficult call, you can give contrast. And on contrast, what you will see that there is enhancement in the malignant soft tissue components. However, benign little hematoma and all will not show any enhancement. So let's again move down to the cases. So here you will see a collapse with posterior convexity. So you know, so there are other vertebral body involvements as well, but no collapse as such. So you see that there is posterior convexity. You think that this is a malignant fracture, and then you see this solid soft tissue component anteriorly as well as posteriorly, that is in the epidural space. So you know that you are dealing with a malignant fracture. Then this another case In this, there is little wedging, not yet fully collapsed with this, but you see a large soft tissue component over here, which is pretty solid over here, solid cystic soft tissue component over here. And another one which you see in next vertebra as well. So once you see these, you know that you're dealing with something which is malignant. Then moving on to another case, so you see a compression fracture, small, it looks like a fracture fragment which is going anteriorly. You see on your actual images, you see some soft tissue edema which is little diffuse and little vague. Doesn't look like a solid soft tissue component. So this is just like a edema post-trauma, and this is not a solid soft tissue component. Ideally, this is not a confusing case, but if you land up with a confusing case, it's ideal to do a contrast and it will clear your confusion. So this is a case of osteoporotic fracture. So these are some points which are restricted to particular vertebrae. But then lastly, what we need to also look at is multiplicity. To be ideally talking about, this might not be very helpful all the time because both the conditions can affect multiple vertebra. But what often and usually is seen that benign or the osteoporotic fractures affect multiple contiguous vertebrae. As one vertebra gets the load and fractures, then the other starts to take the load and eventually they keep on getting fractures. So it's like a kind of a chain reaction, probably you can say. So you see more of contiguous vertebrae involvement with the osteoporotic fractures. With malignant fractures, it's very variable. So depending upon which vertebra is how much infiltrated and got how much weak, depends upon whether it's going to collapse or not. So let's see this example. So you see marrow infiltration and posterior convexity. So you know that this is a case of malignant vertebral fracture. And you see that ideally this vertebra has also some infiltration. This vertebra also has some infiltration. But the vertebra which might be more affected have started to get collapsed. So it's multiple, but the collapse might be variable. As against this case where you see this vertebra, little bit of this vertebra, then this vertebra completely got collapsed. This was almost paired, but then this vertebra got now acute osteoporotic fracture with a big fluid cleft sitting in there. So you see more of the contiguous vertebra involvement one after the other in osteoporotic patients. So just to sum up, what all features we need to look at are these 6 features which really help us to narrow down our differentials. This is a very beautiful article, which is old but great article. Sorry, which sums up all these points with how significant, how much sensitivity and specificity is there because of each and every factor. But overall, we should try to look for all the factors. This is the same thing compiled in a table, which was written by us in a recent book chapter for IRIA. So it describes everything. Just in addition, it also mentions the additional high-end sequences like diffusion and chemical shift imaging, as well as role of nuclear medicine, which is beyond to be covered in these 15 minutes. But when in very difficult situations, these sequences may play some role to help, but you might not always be lucky to get answers on these as well. So better to rely on your basics, which are very important. Thank you so much.
Thank you very much, Dr. Ankita. It's a very comprehensive talk. Thank you very much. We'll take questions for you. Are there any questions? So I'll ask one question about PET scans.
Yes.
On PET scans, how are you differentiating? Just briefly, if you can tell
Yeah,
us.
no, so just we are looking for the uptake which is there on PET. But if it is acute osteoporotic, then also you're going to get uptake. But
Right.
usually with malignant fractures, what will happen? You will land up picking up some other source, which would be the active source, which is causing the cells to be migrating. So you can even pick up the primary source, and that's the most important role which actually PET has to play.
Okay.
So in very acute situations, if only one vertebra you are confused, PET might again confuse you because both the vertebrae are going to show uptake. But
Correct.
if you're looking for a distant metastasis and you're suspecting more of a metastatic, you would be lucky enough to pick up the source.
Right. And another question is, would the location make a difference? Like, say, if you are looking at thoracic vertebra versus the typical thoracolumbar lumbar, where you see osteoporosis more often as
Yes.
fractures?
So if you talk about description in literature, yes, they mention about the location, and in fact, in that article also, we tried to talk about the location that it is more common here. But in practical, if you saw all the examples, you see everything in the same location. So in real life, that really doesn't help that much.
Thank you. Thank you very much. So, are there any questions?
I have.
Yeah.
So you said that hematoma will not be kind of hyperintense on contrast imaging, correct?
Yes, sir.
Like we would assume that like hematoma is connected, it must be connected somewhere to the blood vessels, isn't it? So that dye which we'll put in will not seep into the hematoma.
No, so it's basically a collected blood. Blood would be bright on your basic T1 weighted images, but when you do contrast study, what you do a plain study and you do a post contrast study. So you ideally compare that what this has become from your baseline to post contrast, what has the change has happened. So you do not see enhancement within the hematoma because it's very localized collection. Blood vessel has leaked, sealed off. Now it's sealed off. It's like a sealed off hematoma kind of a thing. So it wouldn't show any enhancement. It is not like something is actively leaking, like an AVM or something you're talking about, in which there is some active leak or probably hemangioma where there are active blood vessels. Hematoma is nothing like that. It is just sealed off. That's why it becomes very localized. So you would not see any enhancement on post contrast images, and it helps quite often.
Thank you.
Thank you very much. We'll move on to the next speaker.
Thank you.
Our next speaker is Dr. Amit Sharma, who needs no introduction. He's a very frequent speaker at both BOS and BSS educational activities. He's a consultant spine surgeon at the Saifi Hospital, and he's going to speak on conservative treatment of osteoporotic fractures, and specifically going to tell us about some risk factors for failure of such treatment. So over to you, Amit.
Thank you, Kshitij. So we know that osteoporotic spine fractures, they occur in elderly people because of the reduced bone density and strength. And because of the biomechanics of the spine, these fractures are most common around the thoracolumbar spine because of the transition from the mobile to sort of immobile thoracic spine. I will not go much into the deep pathophysiology, but essentially there is a loss of bone mass and loss of microarchitecture of the bone, which leads to less space available for the calcium deposition. So the bone will break even with minimal trauma, and eventually the patient will have pain, deformity sometimes, and which will lead to impaired mobility and reduced quality of life. Now, if we talk about the conservative treatment which we'll offer to all the patients who will come to us first, the pain relief is our primary goal. And the secondary goals are, like we have to prevent further fractures. We have to restore the patient function and as much as maintain the mobility so that the patient should not be bedbound. So coming to the pain management, usually we give the same medication which we give for any other situation. Mostly we tend to give paracetamol and NSAIDs for severe cases. For initial 5 days, I tend to prescribe a muscle relaxant also. Nowadays, I prefer thiocolchicoside. If the pain is not subsiding with this treatment, then opioid derivatives. So sometimes, we'll give this buprenorphine or fentanyl patch, which will last for a few days. So patient can cope through this initial, more painful phase. The calcitonin nasal spray is primarily used for to stabilize the bone metabolism, but it also has to some extent analgesic effect also whenever we are dealing with the spinal fracture. So for initial 2-3 months, you can give the calcitonin nasal spray also to be taken once a day. Immobilization, now it is a double-edged sword. We don't want to immobilize too much also, otherwise it will lead to the muscle atrophy. But at the same time, in the beginning, like you give brace for any kind of musculoskeletal trauma. And because these patients are mostly having thoracolumbar fracture, a TLSO or Taylor's brace kind of orthosis is best suited for these people. So in the beginning, I will ask them to do bed rest for a few days till the time that acute painful phase is going on, maybe for 4 or 5 days. And after that, they can start wearing the brace and can sit for the food and for toilet activities. If they are quite comfortable, then they are allowed to walk also and perform some light activities. However, any heavy activity, lifting weight, bending forward, or sitting on the floor has to be avoided to prevent worsening of the fracture, to let it heal nicely, and to prevent any another fracture happening. So activities limitation will be for about 2 to 3 weeks. I tend to call, like, I don't admit these patients, I treat them at home only. So I call them after 2 3 weeks again. Then I repeat the X-ray and I'll check if there is any progression of the X-ray, like on the fracture morphology. If I see something suspicious, then I'll go for the MRI. But most of the time, if patient is going to do well, then X-ray will show sufficient evidence of healing, so that and the most important thing will be the patient pain relief. If the patient is saying that the pain is getting better, then probably we are on the right path. After the initial painful phase is over, then a little bit of mobility training, maybe with the help of a physiotherapist, and some amount of paraspinal muscle strengthening can be started. Very important thing is to prevent the fall. We have to sometimes do the home adjustment so that the patient should not fall on a healing fracture and should not develop any other new fracture also. Now coming to the pharmacotherapy. Now calcium and vitamin D make the like the backbone of this pharmacotherapy. However, there are certain newer medications are also available nowadays, which we'll discuss soon. Along with the pharmacotherapy, it's very important to give the patient adequate protein intake, because ultimately to improve the bone microarchitecture, patient need to have sufficient protein available to the body, and there should be adequate vitamin D and calcium supplementation available. And even though the routine doses are less, but when we are trying to deal with the fracture situation, then the doses has to be increased so that we can provide that extra bit of the medication to help us in fracture healing. Especially during this healing phase, patients should avoid any significant caffeine or nicotine intake and alcohol consumption also, so that so the bone healing can take its own course. So calcium, we know, is the main mineral which is required for bone formation. So ideally, 1,000 milligram per day should be started by all the females who are above 30 years. But when we are treating these patients with the osteoporotic fracture who are sort of proven osteoporotic, whoever comes with a fracture, that then probably the right dose will be 1,500 milligram per day. Now we also have to remember that calcium absorption decreases with age, so that's another reason why we have to resort to the higher doses. And to improve the calcium absorption, we have to give the vitamin D, and we have to give the active form of vitamin D, which is vitamin D3, because many of these patients might be having renal or liver issues, which may prevent normal vitamin D to get converted. So the routine dosage are 400 IU, but in these kind of situation, 600 to 800 IU, or maybe sometimes 2,000 international units per day is also recommended for the 3 months. Now coming to the pharmacological treatment, there are two kinds of medication. One is the anti-resorptive group, which primarily is made up of bisphosphonates, and denosumab is sort of from the same group but a little different. And in the anabolic group, we have teriparatide, and sometimes people give anabolic steroids also, because sarcopenia is one of the major factor which is like we'll be talking about that, which is one of the major determinant whether the patient is going to have the repeated fractures, or is there, I mean, it's in itself a risk factor for failure of the conservative treatment. So these patients, we consider all of them to be high risk, and so these patients should ideally take anabolic agents, maybe inhibitors of the bone resorption in the same sitting, or once the anabolic agent like teriparatide has the period is over, then we can start them on anti-resorptive therapy. So bisphosphonates are given to the people even on regular basis wherever you are suspecting even mild or moderate amount of osteoporosis. These are proven to prevent any fractures in the spine. So most of the time we tend to give alendronate or risedronate. However, because of the patient's compliance can be an issue for these medicines to be taken on weekly basis, sometimes I prefer to give them ibandronate, which is to be taken only on a monthly basis. There are a couple of side effects of these which we need to be very careful about. Jaw necrosis is one of the major thing. So if the patient is complaining of pain around the jaw, then you need to be careful that, and you need to investigate it further. And the other thing is gastric irritation. So whenever you give these medications, patient should be taking these medication empty stomach in the morning, and they should not lie down for about an hour after taking the medication. Especially for the females around the menopausal period, hormone replacement therapy also is recommended, and it works when the bone turnover is high. So that's why it has to be given around the menopausal age, because once the osteoporosis has already set in, then these medications are not going to work. So I usually personally don't tend to prescribe these medications. For that, I'll take help of an endocrinologist. But this is one thing which we need to keep in mind, that is available especially for the female. And similarly, even though one problem with estrogen therapy is that it can lead to increased chances of breast cancer. So raloxifene is one of the alternative which works on the same receptor, and it will reduce the osteoporotic fracture to the same extent without causing increased risk of breast cancer. However, if the patient is immobilized for any reason, it's a post-op patient, or we feel that it's an unstable fracture which needs more of the bed rest, and patient has to be immobilized, then there is a higher risk of thromboembolism with raloxifene. So in these patients, probably this raloxifene therapy is contraindicated. Calcitonin, as I told, that I tend to give it for initial 3 months for the not only for the pain relief, but also it has some it reduces the function of the osteoclast, so it prevents that calcium washout from the bone, and it has been proven to kind of to increase the bone strength over the period of months. But I give it for 3 months only in the beginning, so that the pain controlling effect also kind of works in our favor. Teriparatide are the main anabolic thing which we tend to give. So the only problem with teriparatide is that it has to be given on daily basis, and many of the patients who are they are reluctant to take it on daily basis. As per the books, as per the product description, they have to be given for 2 years. But many patients, they are not compliant, and especially because of the financial issues also. So we tend to give it at least for 6 months. And if somebody is compliant and can afford, then 2 years is the ideal time. So this can be given for the both post-menopausal women and men. And so this is one of the mainstay of treatment whenever we are treating osteoporosis. As Dr. Balakrishnan said, that it probably has to be avoided during if you are dealing with a patient with a CKD and all. So in this kind of situation, and sometimes even with the when the teriparatide is going on, I tend to start the patient on denosumab also. The few practical advantages of denosumab is that it's a once in 6 months therapy. So almost every patient gets ready for taking denosumab. So one injection today, one after 6 months. So nobody objects too much. Secondly, there are no major contraindications. The only one thing which we have to be careful about, that patients should not be taking those oral or IV bisphosphonate whenever you are trying to give the denosumab, because their function is sort of same. The correct dose is 60 milligram subcutaneous twice yearly. So till now, 5 years data is available. Now some 10 years data is also coming up that the medicine, this denosumab, can be given for the period of 10 years also. If possible, I tend to give denosumab and teriparatide simultaneously, but if the patient is not willing to take daily injection, then I start the patient on denosumab at least. Calcium and vitamin D supplementation also should be given, so that the patient is having adequate mineral supply, so that it can get deposited in the bones, and the fracture healing will be faster. Now, combination therapy. So teriparatide and zoledronic acid, when given simultaneously, have shown additive effect. Teriparatide and denosumab given simultaneously definitely have additive effect. The only problem is that which we should avoid is that giving denosumab first and then starting patient on teriparatide. So in these kind of situation, there is progressive or transient bone loss. So that is definitely a no-no. You can give teriparatide and denosumab simultaneously, or teriparatide followed by denosumab once the teriparatide course is over. So this point has to be remembered by all of us. Practically speaking, almost everything works for the vertebral fracture, be it bisphosphonate or denosumab or teriparatide, compared to the hip fracture, where some of the things don't work. And as we know that when we are treating osteoporosis, the doses are slightly higher compared to the when we are trying to prevent osteoporosis from happening. Now coming to the risk factors of failure. So risk factors can be divided in multiple different subgroups. So some factors are patient specific. So if the patient is quite old, like above 73 years, means that the specific age given in the literature. And if the patient is having severe osteoporosis with a T-score of less than minus 2.95, if the BMI patient is on the higher side and with the high frailty index, if it's more than 2.5, then a patient is having more risk of failure of the conservative treatment. So we have to keep a close watch on these patients. And if there is any signs of fracture collapsing, then probably we might have to intervene faster. Looking at the morphology of the fracture itself, if there is a posterior wall involvement on the X-ray, so that probably indicates, as Dr. Ahuja said, that it's a card box thing. So if the posterior wall is collapsing, then probably that card box is sort of collapsing all around. If initial height loss, is more than 50%, then I think that's another factor which indicate that this patient probably is not going to do well with the conservative treatment. Mid-body fracture, because probably like you are in the center of the body, and there's chance you're in the cancellous zone, so there's a further chance of this body collapsing. And also complex fracture morphology, as you can see on the right side of the screen, if you have swelled front or a projecting type of fracture, or it's a comminuted fracture, then probably there are higher chances that these patients are not going to do well with the conservative treatment. Presence of an intervertebral cleft probably indicate an old non-healing fracture, so probably you have to intervene over here. Fracture around the thoracolumbar junction with significant instability are another thing which we have to be keeping a close watch on. There are certain sagittal factors. So if the patient's C7 plumb line is more than 60 millimeter away from the fracture vertebra to the front, then probably there is a continuous front pressure on the fracture line, fracture vertebra, and that has to in these kind of situations we have to be very, very careful that because there is continuous front pressure on the fracture body. If the pelvic incidence is less than 40 or more than 60 degrees, then again we have to worry about. Pelvic tilt more than 27 degree has been quoted in the literature to be having higher risk. On MRI, we discussed some features comparing the benign osteoporotic compared to the malignant fracture. But even for the benign osteoporotic fracture, if both end plates are involved, if there is a cleft sign, if there is diffuse low signal on T1 MRI, or if there is a confined high signal intensity on T2, which probably is indicating a cleft, then we have to be careful about dealing with these patients on conservative basis. And if you are dealing with the multiple fracture, probably that indicates that patient has severe osteoporosis, and again there is a higher chances of risk, higher chances of these fractures failing by conservative treatment. If you see progressive kyphosis happening on the successive X-ray, that again probably indicate that your medical treatment is not working, and then especially in the presence of not non-subsiding or increasing pain, then these fracture probably need something to be done, some intervention. Along with this, if the patient has comorbidity of diabetes or chronic steroid use, or if the patient is already rheumatoid arthritic, then there is a higher chances of failure. If the patient has poor compliance with the physiotherapy or medicine, then there will be higher chances of failure. One interesting factor is that if the patient has had used bisphosphonates in the past, then these patients are more prone to develop that intervertebral cleft. So again, if the patient has a history of bisphosphonate use in the past, maybe because we were trying to treat it in the already and still the fracture happened, then probably these patients are not going to respond to further bisphosphonate therapy. So these patients are more prone to failure of the conservative treatment. Important to prevent the failure, and for that early diagnosis and treatment is required, and fall prevention is one of the major things. But if these things are not working and patient is complaining of persistent pain, progressive kyphosis on the X-ray, or if patient has started developing neurological deficit, then probably we should start off intervening. And what are the indications for surgery and which kind of surgery we can offer, Dr. Samir Dalvi is going to talk. These are the articles which I kind of, refer to while preparing this talk. Thank you very much.
Thank you, Amit. It was quite a comprehensive talk. I think we are a bit short of time, so we'll take questions for both conservative and surgical treatment at the end. So I'll invite the next speaker, Dr. Samir Dalvi. He's also the Vice President of the Bombay Spine Society, and he's going to speak on surgical treatment for osteoporotic fractures.
Hi everyone. Can you guys hear me?
Yes.
Okay, doc. So I'm just going to straight jump into it because, like, as we pointed, there's time. So we've heard about the conservative treatment from Amit, but then what if the pain persists? That's the problem. And the standard answer for that is a knee-jerk reaction, and that is vertebroplasty. And since vertebroplasty came, it's been like a magic remedy or a panacea for everything. And I think it's very important to select it properly. So the patient should have significant pain. Please don't jump on vertebroplasty on day one. Don't jump on patients. I have seen, like in my OPD, patients with osteoporotic fracture of 3 years duration who got some mechanical pain and somebody says vertebroplasty. So no, they should have significant pain. It should be that pain which is interfering with activity and mobility. So there should be some functional problem with the pain. And there should be at least 4 to 6 weeks of conservative treatment because most of these fractures do tend to get better because vertebroplasty came maybe in the late 90s. But before that as well, OVCFs were getting better. Also, you need to know the source of the pain. Like, just because somebody has an X-ray of osteoporotic fracture doesn't mean the pain is coming from there. So basically, you need to select the level. There will be a pushing or thumping tenderness. And on an X-ray, you will see progressive collapse, or you may see a vacuum sign or a fluid sign, which we'll talk about, or instability. The MRI may show a fluid cleft, but more important is edema because this is something which times the fracture. There are many patients who will have very old fractures, but the edema is that which is of a recent fracture or a painful fracture. And a bone scan may also be seen. We've seen a lot of MRIs, but you can see here the edema in the L2, which is sort of hypo in T1 and sort of hyper in T2. And that is very important. This bone marrow edema is the one which will help. And if you have multi-levels and then if you do a bone scan, then the ones which are hot are the ones which are sort of the ones which require treatment. The biggest contraindication is the absence of indication. And I find that like there are many patients who undergo this vertebroplasty where they didn't need it at all. Like either it's done too early, like on day 1, day 2, or these patients are too late and actually the patient doesn't have pain because of the fracture. Infection, of course, bleeding disorders, you need to stop their blood thinners. If there is a cord compression, you can't do it, or the posterior cortex is not intact. If you have any doubt, get a CT. But if the posterior cortex is not intact, you can't do it. Everybody knows about vertebroplasty, so I'm not going to talk about it at this point. Kyphoplasty is somewhere there around the periphery, but it is luckily not in the main thing. I don't think there is any difference in the results between kyphoplasty and vertebroplasty, except that you make the patient pay $1.5 lakh extra. So the complications are something which you need to be worried about. The overall symptomatic complication rates in osteoporotic fractures is pretty high, but in myeloma and METs, it's even higher. And the early complications are cement leak, which is the one which worries us the most, bleeding, anaphylactic reaction to the cement, and thermal necrosis. And in the long run, there may be late infections, which we have seen. Adjacent levels is very important. And peri-cement fracture is the thing which we are seeing the most now. And so what happens is that so many 5 to 15% of routine cases have some amount of cement leak, no matter how good you are. And it may be in the venous plexus, it may be in the disc space, it may be in the soft tissues or in the epidural space. So the disc space is the commonest one because what happens is there's a crack which is communicating with the disc, an end plate crack. And if that happens, there are some people actually who inject cement in the disc, which I found really funny. They call it discoplasty. But what happens is when the cement enters the disc, there is a higher chance of an adjacent fracture or the same fracture. Pulmonary emboli also, because if you put it when it's too thin, you get small emboli in many patients. But larger emboli, you can have a patient dying on table. So that's very important. And otherwise, there can be soft tissue sort of leakage into the tract, etc. So you have to make sure that your cement is set before you remove it. If it's in the epidural space, that's the one which worries about. If it's on one side, you can get a radiculopathy. Hopefully you'll get away with it. But if it's a cord compression, if it enters the canal, then you can get paraplegia and you can do a decompression, but it won't help because that cement will really burn the cord. And so you have to be very careful with your needle placement. And the most important thing is to visualize it. So you have to opacify the cement properly, place the needle properly. It should not go in pedicle, out pedicle, and in the body. And the consistency is also very important. And you see, the thing is, it should be a little toothpaste like when you inject it. It's very tempting to inject it when it's very liquid, but it has to be toothpaste like, and you need to push it with the trocar. So that's what I do. I don't jab it with the syringe. And the other thing is that when you're injecting, you need to do it under continuous fluoro. And you have to have good visualization. If you don't have visualization, you can even abandon the procedure, but never inject cement unless you have perfect visualization. Adjacent level fractures, because this is like literally in a very, very soft bone. This is like a rock hard thing. So getting adjacent fractures becomes very common. And even the same level, you get fractures around the vertebra, which is very bad, around the cement. And you can get distant fractures as well. The biggest controversy came because of this. When there were two randomized trials in the NEJM in 2009, and NEJM is one of the most highly rated journals. And they showed in a highest quality of evidence, which was a double-blind randomized controlled trial of vertebroplasty with a sham procedure, where they just injected local and they mixed the cement outside. And they showed that there was no difference in the outcome. And a lot of articles have come to counter these. But the fact remains that the randomized control trial have shown vertebroplasty not better. And we can discuss this till the sort of cows come home. But in my own practice, I have reduced the incidence of vertebroplasty dramatically. I would do it very rarely. I would do 1 in 2 or 3 months, whereas previously I used to do it quite regularly, because mainly not because it doesn't work. It actually works very well on day one. But I've seen many long-term problems with this, and then adjacent fractures, etc., etc., etc. So what about actual surgery? See, I need to bring up this concept of the vertebral pseudarthrosis. So what happens is, because of movement, there is a micro damage to the bones and impairs the vascularity, which leads to actual and avascular necrosis. And this leads to a pseudarthrosis, also known as a Kummel's phenomenon. And there's a fluid cleft which you see, and this fluid cleft is seen as very bright in T1. And on a CT, it's seen as a blank space. And if you put a needle in, there is actually fluid inside it. And this is what it looks like on the MRI and the CT. Unfortunately, the way the zoom is, unless you can't see the CT, but the CT just shows a cavity. And, that is the fluid cleft. And that is actually a cavity. And you must remember one thing, that there is just bony walls or fragments around that. And the MRI is done in the supine position. So it looks as if it's open, but when these patients sit up, it collapses. So if there are patients who have significant pain, but that fracture is not suitable for vertebroplasty, because it's one of the contraindications, like I mentioned earlier, if there is neurological involvement, failure of vertebroplasty, or deformity. So this one is not suitable for vertebroplasty. What you see, the white thing, the full thing is a fluid cleft. The whole vertebra is a cleft with very little bone. Those two arrows is the only bone. So even if you fill this with cement, this is the easiest vertebroplasty to do, by the way, because you just put the needle and inject cement, and you will feel it's great, and it will fail in 1 week. Because the whole thing just is a blob of cement, and the whole thing will fracture above and below it. And you may even leak the cement or cause a retropulsion. So you see, the whole vertebra is just a bag of fluid. And if you take this kind of an X-ray, you can see the minute the patient sits up, the whole thing collapses. And that is luckily a CT which is showing this fluid cleft. And not only is it a fluid cleft, but you can see that the end plates are all fractured. So if you put cement here, the cement will leak. And there is a retropulsion as well. Neurological deficit is rare in the acute phase, very rare. But in the late presentation with slow progression, it is seen very commonly. So what happens? There is an instability and retropulsion of the posterior wall and a collapse. And over a period of time, this posterior wall tends to compress the cord and cause deficit. These are very difficult to pick up actually, because these are elderly patients, and it's slowly but surely they start going off their legs, and they have transitional pain or transfer pain, and then they start getting weaker and weaker in the legs. The problem here is that you don't see it in the MRI sometimes, because the MRI is done in supine. So all you see is no cord compression, but signal change, something like this. But when these patients sit up, if you take a sitting up X-ray, then it has collapsed. And therefore, when that happens, it sort of causes a retropulsion and a cord compression. If you were to do an MRI in a supine and sitting, which you can't, you would see the cord compression. So it's very difficult to convince sometimes physicians and neurologists that these patients need surgery, but you have to. What about vertebroplasty failure? Something like this again, which is too much of cement, I would say. When there is so much of cement, you can have fracture. See, this is like somebody did a kumal and they thought they've done a great job. But what happens over a period of time, this is nothing. That in 2 or 3 weeks, it starts crumbling, the cement fractures and the bone fractures around it. And deformity as well. So these are the patients who need surgery. So to reiterate, it is neurologic deficit, extreme instability, kyphosis may be an indication sometimes, and if it's not suitable for vertebroplasty. So what sort of surgery do you do? Obviously, it's a decompression and stabilization, but it's mainly a stabilization. But we have two challenges. This is an elderly group of patients with multiple comorbid conditions. And there are surgical challenges because the bone, of course, is osteoporotic. So your fixation is a problem. You can't do an anterior because this is an elderly group, and therefore we do the posterior surgery, and the transpedicular decompression with heart seal actually in the very osteoporotic is my procedure of choice. But I know that this is a lost art. People do not do sublaminar wires anymore, but this works well. You do 4 levels above and below, and you get a nice semi-rigid construct which allows a bit of vertical collapse, and that works the best. You can use pedicle screws, but hold is always a problem. And we also then reconstruct anteriorly. Like here, you see, I put a cage in the space in front and bone graft or whatever. And this little load sharing may help. And then you can use other kinds of screws if you want, the cement augmented, etc. Dual thread. So there are a lot of other ways of spreading this thing. But what's important is you need to sort of have an anterior reconstruction as well. And as I said, these are a lot of issues in terms of healing. They are major procedures, and there are some which you can do MIS. So something like this, which is this patient which collapses on sitting, a vertebroplasty alone is not enough. This is the one which I showed you. So here, what you can do is you can put in percutaneous screws and cement. So you can just do an MIS screws and rod, because that opens the fracture from the front, and then you do a vertebroplasty. So this is the fluid in the cumulus. If you've done it, you'll see this is the fluid which is there in the cumulus. And here you can inject the cement because you got a stability. The whole thing is not going to fall. And put in the rod. And you can see post-op, even the retropulsion has got better, because what happens is when you distract or when you put in the implant, the retropulse fragment goes back. You have to just make sure that the cement is anterior. You don't want the cement coming out at the back. So indications for surgery in vertebral fractures is very rare. And there are significant technical challenges and complications involved. To my mind, the heart seal or the sublaminar wires is beautiful. It's designed for the osteoporotic spine. But as I said, it's a lost art. People don't know it. And I'm shocked to see that now UMA has stopped manufacturing these wires as well. So I really don't know what's going to happen to the next generation. And you can use MIS techniques, but let me tell you this, don't be too gung-ho about this. For MIS, these screws sometimes tends to cheese wire out. And you may have to do open after all, because this bone is really, really soft. So thanks. And Kshitij, I take it back to you for the questions. I finished much earlier than I'm supposed to.
Thank you very much for sticking on time. So we'll take questions. My first question is, what do you do if you are revising a vertebroplasty? What do you do the cement?
So most often I let the cement be. It's very rarely that I need to remove the cement. The only cement I'll remove is if it is infected, right? Because if it's infected and I can easily remove it from the back, and then I need to put in sort of bone from the front. But otherwise, I just let it be. I just do a long posterior construct.
If it is like if there is an instability and things are collapsing and you want to reconstruct the anterior column, or you just...
So I will just push grafts on the side and all. Actually, many of them, after you stabilize, they throw bone and it fuses up. So because it would be a very major procedure. If it's a big blob of cement, then you very difficult to remove it from the back safely. Then you have to go from the front.
I think
you can easily remove it. If it's like a loose bobbing piece over there, it's a different story. But if not, if it's a pericement fracture, you just stabilize and they heal.
Yeah, I think the difference is between those who use pedicle screws versus heart shield. Like, I'm the one who's using pedicle screws more often, and then for me, leaving that instability in the front with rigid screws in the back is kind of a problem. So I kind of go and chase the cement and then reconstruct in the front, which is actually a much bigger surgery than just putting the heart shield.
You also need to know what is the failure. There are different types of failures. I mean, what is it? If it's just a cement, if it's just pain because the bone is cracked around it and you do it early, that bone will heal also. But if there's a huge bone loss or a bone defect, then that's a problem.
Thank you very much. So I think many of these questions about conservative and surgical treatment will come up in the discussions as well. So we'll move on to the case discussions. So I'll invite the first speaker for the case discussion. Dr. Priyank, are you ready with the case?
Yeah, I am ready with the case. I can share it if.
Okay. You can share the screen.
So the
Yes.
speaker will lead the discussion, the questions, and you'll be the speaker will do that. Yeah.
Yeah. So Priyank, you can lead with the questions, and
Sure.
we are
You know who's logged on, and so you can just ask the question to the person.
Yes.
You know who's logged on. You can have a look. Yeah.
Yes.
I think I can see Ayush. No, I can see Abhijit as well over there.
just us speakers are only there in
Oh, fine. Rohan seems to be there. Manish seems to be there. Yeah.
So, so I have a case which kind of summarizes the entire thing that we have discussed till now. It's a typical case of an elderly gentleman who's a heavy smoker, so that's a important part in the history, with back pain and dysfunction in his activities of daily living by a trivial domestic fall. And this is the X-ray of the patient. How do we proceed with this? Do we like jump into an MRI immediately? Do we rest out, or do we start with some basic conservative treatment? Dr. Kshitij, if you only can start off with how do you approach this?
So what I do is that initial bed rest is just to manage the pain, wherein we will try initially IV painkillers and then switch them to oral. So this usually takes to about a week or so to understand which kind of painkillers are suitable, especially if this patient is non-ambulatory. This patient's pain can be severe enough to be bedridden, but if they are able to they are coming to you walking, then I don't give them bed rest. I say, okay, you wear the brace and continue to walk, at least use the bathroom, rest most of the time, but at least do some activity out of bed. And that would be my kind of protocol for activity advice.
And what kind of brace? Any specific brace you advise?
I'm not very particular about the brace. I mean, it can be a lumbar belt or an ash brace. Most people for the thoracolumbar braces are uncomfortable if they are either very frail or very obese. So the brace is more of a kind of a mental kind of a support to them that, okay, something is holding them up and then preventing them from flexing. So a lumbar belt also is good enough to prevent them from flexing. I don't think the belt kind of gives stability to the fracture in any sort of way. So it's sort of optional for me. I tell the patient to use whatever they feel like.
Fantastic. So I actually did the
Actually,
same.
I little disagree here because I think a lumbar brace concentrates it. These are thoracolumbar fractures. So patients with a lumbar brace, it concentrates the thing at the thoracolumbar junction. So I know ash brace is very popular, but it's very difficult to use. So I use a TLSO brace. I mean, a TLSO, which now you get commercially available lighter ones. But in the past, it used to be the Taylor's brace with axillary crushes because this rotation and this flexion extension causes pain. So I would use it for like 4 to 6 weeks. So I'm strict about the brace actually.
Okay. So
I make the patient wear the lumbar belt a little higher.
Okay.
So that's what I do. But yeah, I guess.
All right. So is there any general consensus on absolutely when we need to use a brace or when not? Like Dalvi sir, can you tell us?
No, I use brace in all patients.
In all patients.
Acute fractures, I give them bed rest. And Amit didn't say how long the bed rest is. It is not few days. The bed rest is till the patient is able to get up. I mean, if the patient is screaming in pain, there's no point in telling him to walk around. And if the patient is walking, there's no point in telling him to go to bed. So it is based on the pain and the mobilization. And once the patient is that way pain-free enough to get up and walk, then I make them mobilize with a brace. And like I said, ash brace is popular for some people from Sion, but in KEM we used to use TLSOs, Taylor's braces.
Right. So this patient was exactly done the same thing. Basic pain medications, asked him to start mobilizing within his pain limit, was given a ash brace and was asked to follow up after 3 weeks. Now at 3 weeks, the patient was not doing too well. Do we have a consensus on what is the time when we start doing other investigations like MRI? Dr. Kshitij, would you like do an MRI at this stage? At 3 weeks, he's not really getting better, but he's still walking to the clinic.
No, not really. Means if we have any suspicion that this is which is not benign, then I would get an MRI. So, but it is not the duration that decides on the MRI. I mean, 3 weeks is a very short period to say that symptoms are not improving, especially if the patient is ambulatory. So if the patient is ambulatory, this is a standing X-ray. Patient has pain. I mean, obviously, we don't expect the patient's pain to go away at 3 weeks. So
Correct.
I'll keep doing the conservative treatment. Means I won't kind of chase it unless I feel that, okay, this is not a benign fracture. Then yes, then I would get an MRI.
For me,
So-
it's a little case-to-case basis. So one is, let me see, this patient has a bit of a paraspinal shadow, to be precise, to be fair. So if you look at the left, he's got a little paraspinal shadow there. It could be normal only, but there is a shadow. The second thing is I look at the patient personality and patient profile. So if it's somebody staying in Nepean Sea Road who can afford $6,000 and who will jump at me if there is a met which is missed, then I'll get an MRI even earlier. And if it's just like a patient who's not very high demand, very stressful, then I can treat them based on clinical grounds. So I know that answer is not an academic answer, but it's a practical answer.
Fair. So, so at this,
One-
yes, Amit,
One thing I would like to get done will be the DEXA scan.
a DEXA scan.
Because like many of these patients, like there are some friends of mine who are saying that since they have started using the teriparatide, they're like Dr. Dalvi also said, I think one of the reason why his number of vertebroplasty have gone down is also because of the use of teriparatide. Because many of these patients have started on teriparatide and they heal so nicely. And even though this patient is already proven osteoporotic fracture, like in the severe category, because he had a fracture with a trivial trauma.
Yes.
But again, maybe we would like to document it to understand what DEXA scan, where does he fall in, like on that scale, and maybe starting the patient on teriparatide if possible, if there are no contraindications, maybe with or without denosumab. So that is one investigation I tend to do even when they come on the day one.
Okay. Just the thing, just for everybody, there is a fracture at D12 and this patient has been under conservative treatment for 3 weeks. The symptoms are not greatly improving. At this stage, if we do a bone density, and if you notice, you are seeing aortic calcifications over there. So let's say if there is a very high likely chance that the DEXA at the spine might be normal because of the calcification. In that case, will you still start teriparatide? Or how would you
Then you
explain the patient that teriparatide is needed?
So as I said, this patient is already proven severely osteoporotic.
Yes.
So that thing is like for this patient, you can anyway start. If you feel that there are a lot of calcification in the aorta, or like sometimes patients come with the implant and adjacent segment has some fracture, and you may not be able to kind of identify the amount of osteoporosis on the X-ray, then QCT is is another method. People are coming up with the ideas of measuring the osteoporosis on the MRI also nowadays, but I think we are little it's too premature to talk. But QCT is a proven thing which can tell you about the without being affected by the surrounding implant or calcified aorta.
But
Fair.
you always do a DEXA of hip and forearm as well. No? So you have to look at that. You have to understand that if a patient has, it's not just aortic calcification, it's also osteophytes and degenerative changes. So, and like if there is an implant. So you have to look at all three, because the spine gives you the spine, the hip gives you of a weight-bearing bone, and the forearm gives you of a non-weight-bearing bone. So all of these three together give you an idea of actually what the patient's situation is. But I would never start, like I get very angry when patients come with 3 months of teriparatide and the DEXA is not done. Because if we don't know what we are treating, how do we know what the outcome is? So you have to have a DEXA scan before you start teriparatide. That's my principle.
Sure.
Can I butt in, sir?
Yes, Manish.
Yeah, of course, Manish.
Yeah. So if it's a known osteoporotic fracture, 2-3 weeks he has not healed, there is no harm in starting teriparatide. There are enough studies that it will hasten. It will reduce the time to union. Those are the words used in the paper. It will reduce the time to union. So what is the harm in giving 3 months of teriparatide? Then you do a DEXA and then decide the further treatment. Or even 1 month. Actually, patients have used in 1
I'm
month
not
time
sure,
also.
Manish, I'm not sure that's a very scientific way of doing it. Give 3 months. In the past, physicians used to give people 6 weeks of AKT if they had fever.
No,
So
sir,
that makes sense. If you have to give, you give a proper dose, no? And
Yeah.
I don't think even today there are any solid. I think Kshitij would know better because I'm not an academician. But I don't think there is any solid evidence that teriparatide helps fracture healing, right?
Yes, there is.
sir.
It is only, ठीक है.
So
But
there
I
is no
think baseline DEXA is a must. Like, see, whatever you do, you have a baseline, no?
The
If
patient
you
is in
give iron,
pain,
you do a
barely able
baseline
to
hemoglobin,
travel.
right?
Patient is in pain, barely able to travel. उसको कहाँ DEXA करने को भेजेगा?
I
Yeah, so
agree
you
with
do DEXA on
Manish.
day one. I don't do DEXA on day one. I don't even start teriparatide on day one. It will be after 3-4 weeks when they come for the next visit. I ask them to do a DEXA and come.
Agreed. At 2 to 3 weeks time, when the patient is not showing
Yeah.
response
So I will not
to
do a DEXA on day one.
usual medication.
Yeah.
So it's a general accepted term that if you have an insufficiency fracture, which means WHO definition from a standing height, if you fall and you have a fracture, which is labeled as insufficiency fracture, you can start teriparatide. But generally, it's a good idea that as soon as the patient is mobile, to do a baseline DEXA, because you want to see how the teriparatide is helping. And eventually, you want to decide if you want to shift over to denosumab or any other bisphosphonate. So that's why a baseline documentation is a good idea. But you don't have to do it before starting teriparatide. You can always do it 1 or 2 months later once the patient is pain-free. Here,
The other point I want to make about DEXA is also, Arnav, that of doing DEXA immediately. I mean, I tend to agree with Manish on this, is because like many of them are vitamin D deficient, and you do get vitamin D a deficient patient to do DEXA, they will have a combination of osteomalacia and osteoporosis. Your numbers are very, very low at that time.
And my
So-
other question is, Manish, do you do vitamin D, calcium, and PTH before you start your teriparatide?
I start vitamin D without testing.
No, but that is
I give
wrong.
weekly.
But that is
No,
wrong.
it is
If
not
they are,
wrong,
but
sir.
Manish, that is wrong. If they are having secondary hyperparathyroidism, if their vitamin D is low, you need to give vitamin D first and then check their PTH, and only then you can give
No,
teriparatide.
I'm saying I start on day one. I start vitamin D daily doses, not even weekly. I start daily doses on day one. Once they
No,
don't improve with calcium, vitamin, painkillers, at 2 to 3 weeks time, that's the time I add teriparatide within 2 to 3 weeks time. I
No,
don't
but
wait for 3 months.
I mean, I don't think that is your protocol, but you know, as Amit said, that by definition, this patient falls into severe osteoporosis just because they have fracture. So we know that bone density scans will not predict fractures in 25% of the time. So this is very likely that a patient, 1 in 4 patient will have a normal DEXA with a fracture. But that doesn't mean that this patient should not be treated with teriparatide. The moment the patient is in the very high risk category because they have a fracture, qualifies for a teriparatide or a denosumab or that kind of a treatment. So if you, I mean, I agree with Dr. Dalvi on this, that you cannot start somebody on teriparatide without doing any investigations, because you have a patient who has hypercalcemia, and then you are putting them on teriparatide because their vitamin D was high. You have a high, like, you will see random patients taking 6 lakhs unit every weekly for like God knows how much. Every GP will give them, and their vitamin D is 100 and their calciums are high. And such a patient, you give teriparatide, their calcium will go even higher. So I think best is to do investigation. Everything comes within a day. And there is no need to wait for 3 weeks to start teriparatide. You know that you are going to treat this aggressively because this patient falls into the like a high risk, very high risk category actually. Not even high risk, a very high risk category, because high risk category is just DEXA being abnormal. Very high risk is DEXA abnormal with a fracture. And then these are the ones whom you qualify for these injectables or teriparatide. So as early as possible, but then after investigations. The thing I was telling about DEXA is that if you have very low vitamin D levels, your DEXA is very low just because of like that osteomalacia component also added to it. So you correct the vitamin D levels and do DEXA after some time. Now you will get a more realistic picture, which you can compare after 1 year or 2 year of like giving the treatment.
Having said that, most of the guidelines, international guidelines, are based on the hip DEXA. You don't take the spine DEXA as a standard value.
So you
It is
ask
always, the guidelines are always based on hip DEXA. So having said that,
I
DEXA itself is a
I get
useless
the
test.
investigations at the first follow-up, and I even start my teriparatide after the first follow-up. Blood tests and DEXA, because if a patient is on bed rest and you're starting them on teriparatide, you're not done any investigations, you're going to get a calcium going up. His creat, we don't know what's happening. If the calcium goes up in a recumbent patient, he'll get stones. So you get all sorts of, you land up with a big mess. So I think Like it's
Yeah,
okay.
the testing is
The
prudent,
industry,
but it's
the
not
industry
always
has trained
possible.
us very well to sell teriparatide, but let's not get so much sold to it.
No, sir, it
Let's just take a
reduces the
step
time
back.
to union. It
Take a
reduces
step
time
back.
to union. General orthopedics are using it for their trauma cases also. That's a different
Yeah,
story.
so we've had discussions with, we have had discussions with, thing. This is completely non-evidence based. This
Sir,
is
we'll move
completely
on. We have
non-evidence.
We'll
we
move
have
on.
Anyway,
four
let's
cases.
go ahead. Let's
So
go ahead.
generally starting teriparatide is a good idea. You need to do those basic baseline tests like your parathormone levels, calcium levels, and kidney screening to know if you are giving the appropriate dose or not. Like Dr. Kshitij said, at 3 weeks, this is not a patient not getting better is not so unnerving. And there were no history or clinical signs of any other, sinister pathology. So we kept observing the patient. But at some stage, we got an MRI done and ruled out the other things which are common in elderlies, like tumor markers and just to rule out a myeloma profile. All of them were fine. So we continued with the conservative treatment. However, at 6 weeks, the patient became significantly disabled and it was difficult for him to even move around, in the house. He still did not have neurology. He did not have any neurological symptoms. It was just instability type of back pain, which on a sitting supine X-ray we realized that there is intravertebral instability. There's a Kumel's lesion that is forming, and at this, if someone wants to jump in, Manish, what would you do at this stage? Just continue conservative treatment, or is this a time for intervention?
Radiologically, this is time for intervention. Clinically, is a different story. I need an MRI, of course, MRI, CT.
Yeah, so I don't have those images right now, but MRI and CT both showed Kumel's lesion. The posterior cortex was intact. The cord was absolutely free. And the patient was under observation for 6 weeks. But at 6 weeks, it was getting difficult for him to even go to the washroom. So
Correct. So
clinically
you see
also,
the
he deserved something.
you see the graph of the pain. Always I ask the patient, not I never ask how much is the pain. I always ask what is the graph of the pain. Overall, you are gradually improving. Overall, you are gradually worsening, or you improved initially and then you worsened again. That
Yes.
also happens very commonly. If you see in the supine X-ray, there is a split, coronal split forming. So there is a Kumal's lesion, no doubt, but there is also a coronal split forming at the posterior 1/3 and anterior 2/3 junction. So this is
Okay.
very high risk of collapsing, going into vertebra plana, and having back pain. If this
Yes.
patient had no back pain, then you can still conserve. But if the patient is back pain, then you are looking at some form of intervention fixation first.
What kind of intervention would you do here?
I need MRI and CT, but assuming it is what is in my head, it is a coronal split and there is a Kumel lesion, I will do a fixation. And if you're a very active person, I'll do a corpectomy and a graft cage anterior. If it's a overall senile homebound, then probably vertebroplasty plus fixation plus minus cemented screws. That will all depend on the CT and values on the CT and
Fair.
the
So
HU values.
here, this was the era where vertebroplasty was very, very popular, and he filled in the criteria for vertebroplasty, and that's where we did at 6 weeks. We did a vertebroplasty for this patient, and a month after vertebroplasty, the patient was very happy. He was back to his normal lifestyle. The pain medicine was down, and he was very active. Abhijit, do you have any comments over the vertebroplasty? Do you think it is good, well done? Any critics? Or
No, I think it's well done. I mean, I would have loved to see the MRI before, but since we don't have it, but I would accept this as a good result. Patient is doing well. His activities of ADL have improved. So I think I would regard this as a good result. Yeah.
correct, and exactly that is what. Yes, Amit.
So few things, for this particular vertebroplasty. Number one, you see that there is, though we see it many times, but you can see here more clearly that there is a sort of clear-cut line distinction between the bone and the vertebroplasty cement. Number one. Number two, vertebroplasty does well when it's within the bone. Here you can see that the upper half of the bone is totally gone. So this vertebroplasty is kind of replacing the upper half of the bone. So it is not contained in the box. So that's the second problem. And third problem, which means we can always say the hindsight is always 6/6. But maybe you are trying to come to show us another issue after the vertebroplasty. But assuming that maybe I would say that in some way I'm not very happy with the alignment of this particular, end result. And I'm getting this feeling that this is going to collapse further, especially the rest of the bone, which is there, So that's what the feeling I am getting, that the lower part of the bone is probably collapsed now.
No,
Yeah,
and
so
you're absolutely
my
yes,
comment
sir.
on this is one line: too much cement.
So how do you decide the appropriate amount of
This
cement
is too
when
much
you
cement.
put
I
it?
just put 2 to 3 cc, because if
Okay.
you put 2 to 3 cc and in the EP and the lateral, if you've got a column of cement from the fracture to the upper end plate, the rest of the Kumar lesion at least has the ability to get then replaced by bone. Here, there is no place for the bone to grow. So how will this thing heal? You're just depending on the huge blob of cement there. And as Amit pointed out, there's nothing on the top of it. So this
Fair.
whole thing is bound to fail. That is going to crack below and the whole thing is going to collapse. So
Yes.
this is like too much cement. And I've seen all these patients coming back with failures.
And Dr.
Yeah,
Kshitij,
if I may add,
yes, Manish, is there any
so as I
concern
said, there is
to
a
how?
coronal split. So if you go into that traumatic classification of AO spine, this forms like an A2 kind of a picture. That is an absolute contraindication for vertebroplasty alone. It needs some form of fixation. On top of that, there is something called as a type 2 Kumel lesion. There are types of Kumel lesion also. I don't, my memory is not very clear, but this is, I think, a type 2 Kumel lesion. There's a type 3 which is even worse than this, which has no anterior cortex. This has only a vapor thin and a large movement between the upper end plate and the lower vertebral body. So this is a type 2 Kumel lesion. So this is again a contraindication for vertebroplasty alone.
So I would clearly do, I mean, I think I would not have done this without seeing the MRI and the CT. And if there was a huge cleft, then I would have done this fixation plus thing, what Manish was talking about. Percute fixation plus. Yeah.
And like how everyone predicted, that's what happened. The patient did well, but gradually the pain a month after vertebroplasty was good. But then as subsequent follow-ups happened, the patient has started having instability type pain. And around when we did a follow-up X-ray, the cement had started eating out into the adjacent vertebra. Along with this, yes, Manish.
So this is not cement eating out. This is that cleft which is now collapsing.
Yes. So at that time, so there are few telltale signs on your CT and MRI, which now retrospectively we know that these are not very good cases for vertebroplasty. If there is a significant collapse on sitting and supine, if there are clefts, if the fracture or Kumel's is very near the end plate, or if it is a patient where there is severe osteoporosis, these are those cases where along with vertebroplasty, you would also want to support it by some form of fixation. It could be MI stabilization, it could be open stabilization. So that's the learning point over here. But at this stage, the patient started having some neurological symptoms, imbalance, and we got a MRI, X-rays, everything. So at this stage, the patient is 2 months post vertebroplasty. He did get better and then he started getting worse, and he actually got worse than what he was before, because now he started developing a neurology. So what do we do now? Dalvi sir, if you can step in and tell us.
Yeah, so I would like do a dynamic X-ray, which I'm not sure whether. So that is that the new MRI which is there on the left?
Yes, on the right hand side.
Yeah.
Yes.
So basically, you will do a dynamic X-ray, but obviously, if he's in pain and instability and neurology, you have no option but to do a surgery for this. So
Correct.
you'll have to do like I would do a long posterior fixation. See,
Yes.
his bone is very bad. Even just on the X-ray, look at his cortex is like a pencil, and and look at the difference between the cortex and the marrow. Like, you don't need a DEXA scan to tell you that this is bad bone. And even your screws, I mean, I know you guys put different types of screws, but I'm not sure about that as well. I would just put a long heart shield for this guy, and he's 71 and leave it at that.
You would do a heart shield. Dr. Kshitij, what would be your plan? Like a long posterior fixation means how many levels above, how many levels, assuming this is D12 level, how many levels above and below would you do in this patient?
I mean, I think that Dr. Dalvi's idea is good to do a heart shield for this kind of a patient. Unless you want to remove that big blob of cement, which is, I think, a crazy thing to do.
Correct. And we heard from the lecture that it's really not needed unless there's an infection or it is really loose and going in.
The cement is in the spinal canal, that's a different question. But this cement is not in the spinal canal. So you decompress whatever you can from the back and then put him in heart shield, because the moment you put this patient in a pedicle screws and then even go longer, then also you have a problem, because you have not addressed the primary thing of movement at the level. The pedicle screw is very rigid. And what is going to happen is the screws are going to come out or loosen out eventually. So unless you go all out, get out, take the cement out, reconstruct with a cage, put the implant at the back, then you don't have to go long. Then 2 level up, 2 level down is also fine with augmentation.
Yes.
I do
What about just
sublaminar
MI
I
stabilization? I can.
Ah,
Can I
What
say
about just two
Abhijit,
levels above and 2 levels below MI stabilization with cement augmentation? Why not that,
so
Kshitij?
cement augmentation is already done. You meant
No,
cemented.
with the cement augmented screws, penetrated screws. Yeah.
So two about 2 below MI stabilization with cemented screws is a
Yeah.
absolutely justified answer. We heard Dalvi sir
Yeah.
and Dr. Kshitij both tell us about the hard shield fixation. I could see Rohan disagreeing with Rohan. What would you do? Would you agree with the hard shield or you would not?
No, so from the very beginning, if I just summarize this case, this is
Yeah.
a burst component of an osteoporotic fracture at the junctional level.
Sure.
So there is no way the cement is going to hold up, because when we talk about injecting cement in a cleft, they are mostly in the compression fractures where you have only the failure of the anterior column if you consider the tricolumnar theory. Here the fracture has failed both in the anterior and the middle column. This is a transitional area of the spine. So this is a day one fixation with
No,
whatever
that's
anterior
absolutely,
reconstruction.
absolutely
You won't have
agree
time
that it was a bad choice to do vertebroplasty. But
So
what
now what has happened is, over time, why she developed deficit is because of that repetitive abutment of that fragment.
Yes.
So even if you position her and if that aligns well, I would have still done only a percutaneous fixation and gotten out.
So 2 level above, 2 level below?
Maybe 3 up, 2 down. Yeah, or 2 up, 2 down. Yeah.
Sure. So here we did that. We did 3 up, 3 up, 2 down. I'm extremely sorry that the lateral X-ray I'm not able to find out, but this is what we did. Now, somewhere we heard Dr. Dalvi say that Hatchil is a better choice over there. Somewhere experience is
Can I-
at play.
Yeah,
Yes, sir.
can I tell you one more experience?
sir.
An experience of failure. See, this percutaneous screws is all very attractive, and it's
Correct.
very easy to sell it to yourself and sell it to the patients. But what happens honestly is that this bone is so soft. I mean, you may do your cement augmentation, you may do all of that. But what happens is that these screws loosen when you're putting the rod, because that the system of reduction putting the rod is so important, is so strong, that what happens is that the thing gets pulled up. Now, in a normal patient, your spine will correct slightly and sort of connect to the rod. But in this osteoporotic patients, there's a little pull out. So that pull out starts, and then you see over 6 weeks, 8 weeks, the whole system starts pulling out. So that is why I don't like. I'm somehow against. Like I'm moving away from doing percute screws in these patients, because especially the Indian ones, which have those outriggers where you just tighten. So it all looks great. You tighten everything, but it's already pulled out. You see the last X-ray, it's already pulled out a bit, and then you leave it like that. What can you do? And then the whole thing pulls out in some time.
Sir,
So that is a problem. Whereas when you do it open, you put the screws properly, you can angle. If you made any mistake, you can change the angle. You can hit the anterior cortex. You can hit anything you want, and you contour the rod. And if there's any problem, rather than pull the thing up, you just contour the rod a bit more, which you can't do when you do it percute. That's what I feel. But take a percute, you do percute if you want to. But I'm just saying this is a
True is, like as an
Yes.
orthopedic surgeon, I mean, I'm not able to digest the idea of instrumenting without fusing. So, especially in these patients where, where we are probably going to keep these screws longer compared to a traumatic fracture in a young patient where we maybe remove the implant later on. So, if you are putting the screws, but we are not fusing those segments, they are bound to loosen up eventually.
Yeah.
So, and with the screws, you cannot fuse, obviously.
Okay, so I think we'll move on to the next.
Yeah, so just quickly, we exactly did that, open, stabilized it. But as Dr. Dalvi had predicted, since there was no anterior reconstruction and the screw, as Dr. Kshitij said, is a rigid fixation, slowly the screw started pulling out at 2 months. At 4 months, it started pulling out even more. And then the patient again was disabled because the inferior screws were irritating the nerve root. So we had to revise. In the interest of time, I'm just going to go ahead and tell what we did. We revised it and eventually went back to what Dr. Dalvi had said. We changed the implant system to a hard shield sublaminar wire. And this is a very good implant system, especially in these cases. People who have not had an experience should know about sublaminar wires, because there is an advantage of that extra cortical hold.
the lamina is cortical bone, and that is relatively preserved as compared to the body. And there is an option of an axial collapse, just like a DHS. So there is some play that happens at the fracture side. So this is a very good system which you can use, especially in patients where you have severe osteoporosis and you are forced to operate these patients without having had a chance of correcting osteoporosis with teriparatide. With that, I would end and let the next speaker come in. Any comments before I?
No, so I think we are way over time.
Yes.
We have others to present. So the next one, next speaker, Rohan or Abhijit, whoever is ready.
Yeah, Rohan, can you present my case? I would.
Yes, sir.
Rohan,
I will share your case.
I'll
first.
share. Rohan will share the screen. I'll
but then
present the
please
case.
keep it short and go to the
Yeah,
problem.
sure.
So don't stop
Yeah,
at every
yeah.
level.
Yeah,
Just
yeah,
go to the problem question.
All right, sir.
Yeah.
Is the screen visible now?
yeah, yes. So go to the case presentation, Rohan. Yeah, so this was a 76-year-old female. She had an L4-5 fusion 4 months before she presented us with severe back pain and difficulty in walking. She was almost non-ambulatory with extremely severe back pain. She was ambulating with support for 2 months post-surgery with pain and discomfort. She came to us with wheelchair-bound status and comorbidity. She has diabetes, she's obese and osteoporosis. The patient is on examination, patient wheelchair bound, not able to stand without support, power grade 3 in the right ankle and EHL and ankle dorsiflexion. Rest is grade 5, bladder bowel is not involved. Go to the, so this was her X-ray and the CT scan on presentation. So she had an L4-5 T-lift done about 4 months back, and she presented with a fragility fracture at the L5 level, with severe pain and weakness in the right lower extremity and difficult to walk by herself. We have the MRI as well, I think. Next slide. So this was the MRI. So what would we do in this patient who is 76-year-old patient who is obese? 4 months back, she had an L4-5 fusion surgery and she has L5 fracture, coronal split fracture. The implants have pulled out and she has a neurological deficit and she's not wheelchair bound, not able to walk at all.
Do we have the post-op X-ray of this patient, immediate post-op? Like, was it done like this only?
Yeah, that was the.
Also in
go
that
to the
cage
previous
is also
slide,
there
please.
in that. See, look at the cage.
So,
the cage is in L4.
Yeah, the cage was in the vertebral body. Yes, it was in the vertebral body. Yes.
The
implants had backed out. So this is how she presented to the emergency room.
Anyway, fine. We'll take it from here.
CT scan.
The L4 what? This is the CT scan on the right side of the X-ray. The CT scan.
I mean, the answer is simple, but the feasibility and the results and in terms of complications and all is, the answer is obviously simple. You unscrew it by these.
So I have a question here. As in, of course, we extend the whole thing, but the whole in an osteoporotic spine with a tall L5S1 disc, that L5 gone, that L5S1 junction is going to be highly unstable. So how would you reconstruct that L5S1 junction?
Yes. I mean, do you remove the cage?
You
I
have
do
to
the perfect.
you have to go to the pelvis for sure. You have to get as much fixation distally as possible and hope for the best. And yeah, the L5S1, you probably will have to do a T-lift there as well. So I don't know whether even at L4-5, you'll have to do something and at least put graft or something. And then above.
Do you remove the cage or no, sir? Do you remove the cage at the L4 or?
I don't know. If it's easy to remove, yes. If it's not, then it's just, if it's got only that much, if it's easy to remove, okay. But if it's not, then you don't have to struggle to remove it because it's only that much volume, that cage ka jitna hai, only that much of a hole it has made.
And then spend money on BMP.
Yeah.
BMP maybe.
Yeah. So,
I mean, this is a different problem. This is a difficult problem.
Let's go to the.
Like previously, they used to say, infection is the bugbear of orthopedics. But I'm thinking osteoporosis is the bugbear of spine surgery. Yeah? Now, no matter what you do, if
this is an FDA label use of of BMP. You are not even doing off-label.
Like Abhijit, if I may, she's an old, overweight lady, and we've already operated, and she's now in severe pain, probably more than what she was before the primary surgery.
Yeah, extremely severe pain. Yeah.
At this stage, I wouldn't try anything conservative. I would open up. I would go 2 above, and 2 below. Basically, do a lumbopelvic fixation. Not really try to get the hardware out because there's no infection over there. I'll just span the entire area and start.
But the implant is loose. The
Yes,
implant is backed out.
so the thing is that the screws which are loose, I would, if you see the cage is well within the body, it's not pressing up on any neural structures. So instead of taking extra attempt to try and remove that and cause more harm, the loose screws I would remove. If they are not loose, I would let it be. But do a lumbopelvic fixation, do a copious amount of posterolateral bone graft, start the patient on teriparatide, support and protect the implant with a customized frame type of belt, and let her be restricted for till the fusion happens, till everything solidifies. Like, I'm sure the first surgery was not bad, it's just the biology failure. So if you give 3 to 4 months of teriparatide, it is going to improve the bone quality, and till that time you protect the implants with a fixation. Because she's old, keeping her bedridden and in pain is not a good idea. So that would be my plan.
My question here is, how does a L5 break coronally with the screws going through the pedicle? How did that happen?
Yeah, that is even I don't know.
That is a good. There has to be a good reason for it.
No, there was no history of any fall, nothing. I mean, she just this is the patient just presented to the emergency room like this,
I feel the cage has digged into the inferior body, and that's where
the body and it
fractured, and then the screw started pulling out. But then it might work in our favor. If the cage is in the body, it might, facilitate eventually.
Anyways, besides the point.
Show us the surgery.
So go ahead, next slide, Rohan. So we did exactly what we discussed right now. We went next slide, Rohan. So we went from L3 to S2 post stabilization with fusion. We did not remove the cage. We did interbody fusion at the L3-4 and lot of interbody fusion at the L5-S1 with only bone graft and the cadaveric bone graft. We did not use any cage at that level. We did not remove the cage as well because we felt it would lead to further bone loss at that level. We went to the pelvis, started around calcium and teriparatide post-operatively. At the L3, we did a cement augmented fixation to make the construct more stable. Now this patient is almost 1 year post-op and she is walking without support. We have a follow-up video and X-ray, which is not in this slide, but she's doing well. Yeah. So, Dalvi sir, any comments from your side?
No, well done, and its work is good. So that's good show.
Okay, thank you, sir.
And I'm assuming you also worked on, you must have said it, right? Teriparatide and denosumab.
Yes, sir. Usually I do involve rheumatologist just to before I start, aggressively on.
There's a newer drug now which these guys are trying to sell us, and I just spoke to a endocrinologist who said it's much better. It's $25,000 a month,
Evenity.
one injection a month. It begins with R and ends with atide.
Evenity, romosozumab.
No, it's rumosumab.
Rumosozumab, I think.
Rumosozumab, yeah.
And Dalvi sir, if I may add, I have actually had the opportunity of using this drug because the patient had come with multiple osteoporotic fractures, multiple vertebroplasties, and on denosumab. So generally I was stuck. Teriparatide would have caused a little bone loss. So I actually used this medicine and I was actually pretty impressed. Within 3 months, there was a significant improvement of the bone quality on the CT. The only problem is that in a patient with previous history of stroke or MI in a year, you cannot use that. So it's coming in.
Yeah,
but
so we need to know more about the drug and we need to be educated a little more about it.
Yeah.
So, but
I can quickly start my case now. So she's a 67 female, failed conservative management. She comes with this MRI. And she comes with support when she walks and she cannot independently do so. So these were her images. This was the only MRI available. So I always kind of over-investigate these patients in the form of CBCSR, CRP with a sitting X-ray where you can see that there is significant amount of collapsibility. And along with that, a serum protein electrophoresis or an immunofixation. What my question is, do you all do CT in the same sitting when you see such a significant amount of collapse or not? Kshitij sir, Dalvi sir can take this one. Like you can see the MRI supine versus the sitting X-ray. And do you do CT day 1 on this patient or not? Like along with the serological parameters?
No,
No,
unless I
no.
have surgery. Otherwise, no.
So she's come with 3 to 4/5. She's gradually decreasing, and this has been happening over 2 months. So she's following all those classical, the classical history of a Kumel, where she's gone into intravertebral non-union, and there is a local segmental kyphosis happening at the thoracolumbar junction, and now she's come with a deficit. Now, do you before
But a CT will help you differentiate between a Kumal and because that X-ray and that MRI looks a little funny. That doesn't look like a Kumal. It looks like a diffuse sort of marrow change. So it could
but
be.
on the sitting X-ray, it's completely collapsing, sir.
That doesn't matter. Even if whatever it is, it can still be a malignant thing. No? So one doesn't know. So I would say that CT will help. I mean, I would like try to get some more information if it's looking so funny.
Yeah. Okay. So along with the other things that were negative, I went ahead and I did a CT. So this was the CT scan, and you can see that
there's some lysis and I don't know, different odd.
So
this is a fracture. Looks like more like a fracture.
Yeah, and
multiple
also
myeloma parameters were done for tumor parameters were done, Rohan?
Yes, sir. Yes, sir.
Okay.
So
And what
now,
they were negative or?
yeah, the negative. But the thing is now when they come with neurology, like a 3/5, what is your like approach with these patients?
No, if this CT is the same time as that X-ray that you are showing, then this is unstable.
Yeah, this is
X-ray shows it is completely collapsed, and CT shows it
that's
is
what
unless
opening
both
up.
are at different times.
No, sir. So basically, if you see the CT and the MRI, the degree of collapsibility is much lesser when it comes to the weight-bearing X-ray. So it is collapsing on X-ray, but it is opening up on the CT and MRI.
So this is unstable then.
So now again, to a question to the chair, what will we do? So this is the picture currently. Like I showed you all the 3 things at the same go so that we can easily see as to what is happening. So now my, oh sorry, this is wrong. Yeah, so now what would we do? Do we conserve and brace? Do we decompress?
What is the age of the patient, Rohan?
67, sir. So do we decompress? If yes, then directly or indirectly? Do we stabilize it? If yes, with special screws, FNS, coated? Do we reconstruct anteriorly in this case or not? Like compared to as Dr. Priyank had earlier shown, I think this is a very similar case. So how many of you will consider anterior recon in this along with stabilization? Because
a lot depends on how the surgery goes. Like it's not you don't, yes, you have to always make a plan, but sometimes the plan changes on table.
Yes, sir.
You need to sort of decompress, then you need to go transpedicular and see. Now, if the whole thing is coming out, and also it's very important to send the vertebra for biopsy.
Yes,
no matter what it looks like, you never know what it is.
Yes, sir.
So, you make the patient prone, exposed, do a fixation and all. They don't go transpedicular and see. Now, if there is a bogda or a gap in front which needs to be reconstructed, then you reconstruct. This is not one where I would put cement because there are too many end plate fractures.
Yes, sir.
So this is not that cemented wala. This I will reconstruct with bone or cage.
Kshitij sir, do you think that the amount it has collapsed, suppose when we position this patient under anesthesia and it opens up significantly, what it also says is it's that unstable as well. So that also for me is a strict no-no because the volume of cement increases when I do the anterior recon because it opens up a lot.
So that cement in such kind of a patient will not be a reconstruction of the anterior column.
Yeah.
It would be even a bigger problem if you put cement, reconstruct from the back and everything collapses, you have a bigger problem.
Yes, sir.
Because now you have cement in the front.
So one of the earlier cases that had done
with cage or some bone graft or something like that.
This was one of the earlier cases which taught me that anterior reconstruction in such patients is absolutely yes, because this is a teriparatide treated patient with a classic 2 up, 2 down. Although the fracture is becoming sclerotic, but you see the implant is still failing below. And now there are other options like these, like where you can go with an FNS through and through in the index vertebra, or you can do a vertebroplasty with a percute 2 up, 2 down. So what I chose was, because I wanted a relatively biologically superior construct, I went in. This is what happened on table. So this is how I positioned her. And you see the amount it has opened up from the sitting X-ray. So this shows that there was a lot of space, and this in itself, like how Dalvi sir said, does not allow us to decide that you will go with one definitive plan. You should have 2, 3, in hand. So what we did was, I went in, I put in a cage. I did not decompress posteriorly. I just fired in a nice peak cage with a classic 2 up, 2 down. And I went transpedicularly. I took biopsy from there. and I preserved the midline because, here, if you just restore the coronal and sagittal alignment, I think you can get away, because to understand that why the deficit has happened, it's because of the repetitive abutment of that retropulse fragment over time. It is not something which is acute. So I just coronally and sagittally realigned this, and that's her at post-op 3 months and 6 months. And that's her at post-op compared to 1 year. You see, the entire thing, thanks to the osteoporotic medications we have, has taken up, and from the Kumal, it has completely consolidated with a much more biologically superior construct where the anterior column is also reconstructed. So this is what we are doing now. We are doing something like an indirect decompression with a cage plasty. And this is another case that we had done over time. This is just to show that how at 1 year, they really do consolidate, because we are giving a bigger strut anteriorly, so it does not fail. Plus, I'm worried about when they open up a lot, I don't know to what end and how much volume of cement I have to put. So in that, this is his 2 years CT, and that's him. This is another case which I was showing. So this is the 2 year CT, and we always get them done to show that how nicely the cage has been incorporated both in coronal, axial, and sagittal. So this was one thing which I realized, that there are many ways to indirectly decompress and get away, especially in patients with 3 to 4/5 neurology, because they all improve with time if you reconstruct them anteriorly and maintain the coronal and sagittal alignment. So any opinions, any takers? If you all differ, you all agree.
There was another fracture.
Yeah, there was another
an L3 fracture as well. L2
yes,
fracture.
right. So that fracture also.
So you did stop just before that fracture. So
yes. So that is exactly what I wanted to point out, that at 3 months, because of the teriparatide, if you see, the sclerotic rim has already formed on that thing, the distal to the distalmost screw, the body to the distalmost screw. There was some marrow edema, but we let that be, and we did a classical 2 up, 2 down.
I think teriparatide is given more credit than it is due.
I know all of you are really sold by teriparatide. You should be like me. I will not talk to MR that much.
No. Sir, if you see recent literature, it is used. I mean, forget about reversing osteoporosis, but in short bursts, it is proven time and again that they are now enhancing fusion. I'm not talking about reversing osteoporosis.
So, Rohan, I don't agree with you. So what I will say is that you please send those papers to Kshitij, and if he agrees, then I'll agree.
Sir, I will add to this. If I have such kind of a failure, two I have had such failures, and I've added teriparatide plus denosumab. The results are fantastic.
Anyway, so that's
okay.
That's a 2 part. My only thing is, Rohan, you keep saying classic 2 above, 2 below. Maybe classic where you come from, but there is no such thing as classic. If you ask me today, I would do, if I'm doing screws for osteoporotics, I will do 3 above, 3 below. And I'm like one big lazy guy who doesn't like to do too much surgery. So if I'm putting 3 above and 3 below, there's a reason. And if I do Hartchill, I do 4 above and 4 below. Wow. Because anyone who's worked with me knows that I'm lazy. Introp, I always do less than what I plan to do.
But in those cases, do you always anteriorly reconstruct as well?
Yeah. So the anterior reconstruction, irrespective of that, means I will not say I'm putting 6 screws, therefore I'm not going to reconstruct anteriorly. That is different. But I think 2 above, 2 below also is not good enough for these osteoporotics. 3 unique, require 3.
Okay, sir. Okay, thank you.
Am I to present?
One more case, the Manish's case is there.
Manish, go ahead.
Sorry, this is a very quickly made.
Yeah, we are not very bad on time actually. We are just, it's okay.
Okay. So, so the 77-year-old female started imbalance of gait about 3 weeks time. Gradually worsening. She used to feel wobbly, and then she started falling. Weakness in both lower limbs. Some on and off. Not objective but subjective numbness. Then reached just about 2 days ago, patient started developing loss of bladder incontinence. She lives alone. Children are in US somewhere. Examination wise in casualty, when we saw, she was tender at D11, power of 3/5, not able to walk. Not in retention though, but she had some urinary symptoms. Sensations were normal. Known case of diabetes, blood pressure, and rheumatoid arthritis on medications. She already had a DEXA hip from about 4 months ago, and DEXA hip was minus 3.7, spine was minus 4.5. So these are the X-rays. There are obvious one fracture here at L1 which looks healed. There's some collapse here. This is a stitched AP X-ray. we got an immediately MRI done because of the deficit, and this is the picture. Should I continue or wait? So there's some cord tenting here at D11, D10. And
Question is going to be surgery only. CT scan.
right, we have a CT. Anything specific anyone would like to point out on the CT?
So there is some compression from behind as well. Like there is this small dent at that junction, no?
Here?
Posterior.
The fracture in the posterior element, no? It's like you can
Exactly,
see
yeah. So there is a fracture, it's like a chance. So basically, it's like a chance kind of fracture.
Which
Yes.
you can't talk about compression in this at all because this patient, it's instability is the problem.
Yes.
The MRI is done in the supine position, right? So this patient's deficit is because she's trying to walk. So it's the whole spine is unstable and the cord is just moving between the two.
There's some subluxation also probably on standing. We couldn't
Yeah.
get a standing X-ray done. So this is a prone shoot through lateral. I frequently in deformity and osteoporosis, I get this X-ray done, prone shoot through. So lower one is obviously healed. So this is the culprit. So this is I was talking about the types of Kummel lesion. This is like type 2 Kummel lesion with the anterior defect. So I'll proceed ahead. These are the HU units at the level that I was proposing. So these are the main HU units of 67, 50, 47, 41, 34. They're absolutely abysmal Hounsfield units. We didn't do a, I think DEXA was already there, so we didn't repeat it. But this is like a gross discrepancy from even DEXA, far worse than what DEXA would show. So if you see, mostly if you are looking at Hounsfield units, you want good quality bone is definitely a normal healthy bone is unit size should be more than 200. Anything less than 150 is osteoporotic. This is like in 50s, 1/3 of osteoporosis. So again, the question is we have to do surgery. The question is what implant and how to reconstruct.
Marker?
Sorry?
My answer to you all only. So
Myeloma markers are negative, right?
yeah, so that also you have to,
Myeloma is negative. This is not
forget,
myeloma.
yeah, you should not forget the other workup as well. Like, but anyway, my thing is that you should biopsy also you must send. Like, I don't mean preoperative biopsy. I mean
During the
But anyway, as in assuming whatever it is, you still have to your first priority is fixation.
This patient has to be operated. Yeah.
So these are the various things that I do. So I do heart shield, I do corpectomies in osteoporosis, I put cemented screws, I put index level screws also, but without cement at the upper and lower level. How would you kind of go about this? Okay, I'll just show what I did.
Yeah, but
so I
would
went.
myself.
Yeah, this is the immediate post-op. So it went 3 above, 3 below, as the research said, but I also put cemented screws, did a vertebroplasty above, anticipating, sorry?
You went 4 below, no? 1, 2, 3, 4.
4 below. I think that because of that one fracture there, I didn't want to end at that old fracture. So
But that fracture was healed, Manish, right? It was healed fracture.
Yeah.
Even if it just.
It was healed.
You could have just treated the upper one, the D11 fracture, and even one level above and one level below with the cement augmented stabilization with the vertebroplasty would have also done well. Because
One
she's
above,
77,
one below, one above, one below, not at all. It is a completely
MI cement augmented.
Nothing. Super 100% failure. Power is 100% failure. If you are done that.
But the DEXA was, I think the bone density was absolutely pathetic. There was nothing.
100%.
She's doing well.
Can I add
2 years
something?
follow-up, she's doing well. So I think that's a fair.
Sir, one way of knowing that the bone density is bad is when you put those fenestrated screws, you see how you have a scattered distribution around that of the cement also in the body. Because the trabeculae are so thin, when you're firing the cement actually seeps through them and you have a scattered distribution. If you had good density compared to what it is, you must have a more concentrated kind of a thing around your FNS also. So that is one way of knowing that this was very, very, very poor as far as the density goes.
So I added some sublaminar wires here, and when you're doing cementing, the best quality, the best results are when the cement touches each other. Both the screws cement should touch each other in midline. So that gives the best quality hold. So I've got it at most places except probably at the lowermost, and the one here. So and I protected
did this
my
work?
construct
Did
with
it
a
work?
vertebroplasty above.
Manish, did this work? You're going to tell us?
Yes, this is 2 years follow-up.
Okay.
And
So
I've added
I have two
sublaminar
things to say.
wires.
I have two things to say. One is that, and I'll let Kshitiz speak after this, but he uses Mercilene tape and he's got evidence that this works well. So he uses Mercilene tape in addition to screws and rods, and I use sublaminar wires because I'm not very this thing. The other thing is I am a little slow to take anything new, and I'm still a little skeptical, but now less after seeing your cases about the cement augmented screws. So I have some basic principle problems with them. Like one of them is like that whole vertebra is now filled with cement, and the problem is not the hole as much as the bone. So I feel that if the whole thing cuts out with the cement, you land up with a super disaster, and then you can't really revise these either. So I have not done even one of these cement augmented screws, but I think you guys are doing them, so I guess it's okay. I'll start doing them.
Your concerns are absolutely valid. This is what it's a dreadful thing to have a complication, but for that your alignment balancing is paramount. If your spine is unbalanced, those screws are going to cut out whether you put cement or no, you don't put cement. If I think I'm not going to get good balance, then I go for a hard shell. The balance doesn't matter.
I have one question. I mean, for the 77-year-old patient, I think this is too much surgery for this patient because the L1, the lower fracture is healed. The main concern is the D11 fracture where there's compression and retropulsion. So why go and fix all the way above and
This is a 3-column injury. This is not a simple osteoporotic fracture. This is a 3-column injury. So you can't go one above one.
Yeah, I agree with 3-column injury.
Basic. This is a basic rule
Maybe
for any
about two levels
injury.
above, 2 levels below.
No,
I don't know. I don't think it's too much surgery because it is one incision and it's whatever it is. And the other thing is too much surgery would be if it fails and you have to do it again. So if you do something less this time and then you have to redo it, that is too much surgery. So I think if you get one chance to get it right, and he got it right. So that's good.
So I am also very uncomfortable putting in cement augmented screws, especially for benign disease like metastasis. Fine, patient not going to live very long and all, which is actually the true indication for cement augmented screws. It's fine, and I have sort of the same concerns as Dr. Dalvi that God forbid this breaks, or even if, for example, even if it breaks at the proximal level, if this patient gets a PJK. Which is not uncommon. In spite of our best efforts, patients with osteoporotic fractures with long construct get PJK. And imagine having a PJK with a cement there at the top screws, reconstructions with a VCR with a cement in the front. It's kind of a nightmare situation. So, I have been doing it with Mercilene tapes. I also will do similar thing like what you did. I'll just add Mercilene tapes, but I won't put the cement at so many levels. But I would go long. There is no question to do short for this kind of a person. It would be a problem if short fixation is done. But
the holy grail is combination of teriparatide and denosumab right after surgery. I'm telling you this again and again. Give a combination of teriparatide and denosumab for such patients. She had literally no bone.
I think you've done a good surgery. That's why it has worked. So
no, but I'll tell you what, see, whether what all said and done, no matter what surgery you do, if the bone is bad, that's going to fail. So if the thing works, the basic issue is you do whatever you want, but if the bone is only not good, what is going to how is it going to work?
For the cemented screws, your balance has to be fine. So which is why if you're unbalanced, then no matter what you do, the screw is going to cut out. In such cases, you go for hard shell wires.
But Manish,
that's what I would do.
How many balanced spine with adult deformities get PJK with long constructs?
Fair enough.
The number is very high. That 20% is very high. Now, you were in that 80% bach gaye. But if you would have been in that person where you get a proximal fracture, which is not uncommon for a person who has 4 fractures already, this thing is going to give you a nightmare to revise.
No, but if you
that's the only
balance it well, give it a good fixation. I've added a vertebroplasty above, and then you treat the osteoporosis very aggressively. I think I've done about multiple of these, not in single digits, but fair number. None of them have failed. None of the cemented screws have failed so far.
Have you used a couple of cemented screw?
Sorry?
Have you ever had to remove a cemented screw? like
No,
a
not yet.
fenestrated screw with cement.
Thanks to God.
How
not
you
yet.
can't remove it only? How can you
Yeah.
remove it if the cement is inside the screw and
No, you
going
can
to the
remove.
This was a.
It
You see this
No,
one. This
you
is
can.
again. This is
Should
again
not
my
be.
patient. 2 above, 2 below, and those are all cemented screws. But I've
Yeah.
also done a solid anterior work. So that 4-year follow-up with a good fusion in a
No, the
osteoporotic
screws can
patient.
be
which
removed,
is-
sir.
Okay.
Like I have done cemented screws, but I have done the old technique where we fill in the body with cement.
First do a vertebroplasty and
Yeah,
then
first do a vertebroplasty,
There-
let it dry down, then put
so
a tab
there-
and put a screw over it.
Priyank,
Cemented
those
screws is
those
standard for
fixations are
metastatic.
not as solid as
That's
fenestrated
not
screw.
good as
What you're
right.
talking is a cheaper way of doing it. I also do it, but those fixations are not as, at least biomechanically, they don't give the same rigidity as this one.
No, see, a fenestrated screw, the cement column is in the screw shaft going out through the holes and hitting the cement, right? Whereas this other method is you're doing a vertebroplasty basically, and then you're putting a screw just to get a better thing surrounding your thread.
So
So
sometimes
you try it once, it's not the same hold.
because it depends on a lot as to where the fenestrations are also, whether they are at the tip or just proximal to it, or they are in midway to the screw. That will actually decide the hold as well.
And whether it's
Okay, by
front,
the way,
front or at the side, that's another
Yes, sir.
thing.
Yes, sir.
The front one, just imagine while putting the thing, if like I just get nightmares, like while doing the thing, if you made a breach anteriorly and the cement goes out anteriorly,
Correct.
you know, so
I agree with Samir sir. Like I would like to do something where I know that I will be able to salvage if there's a problem. So that's why I'm a little skeptical, but excellent
a
case.
complication of hardship. So you see that wire here was so bad. So that
yeah, of course.
I have removed the screws, this cemented screws, and I had no problem removing it. Actually, you don't have any problem removing it.
Abhijit, problem is not removing the cemented screws. Problem is having a fracture in a body that has cement.
Acha, yeah.
You got what I'm
Proximal,
saying?
you're talking about the proximal body.
Problem is you have a fracture that has broken because this is stiff. Baju ka soft hai.
Right.
You
Correct.
have a fracture which breaks in with the cement inside. Then
Correct.
you are basically.
Yeah, that's a challenge. Yeah, that I agree.
And sir, one more thing is when you do such long constructs, over contouring the rod will always help rather than under contouring, because that actually increases the pull out capability when it comes to PJK or DJK also. So if the rod is in sync with the upper uninstrumented area of your spine where it has been neatly contoured or even perhaps over contoured, it would really help. I mean, one of the reasons why they used to fail in MIS is because we used to under contour the rod and then the screw comes to the rod and it kind of pull it back. But once you over contour it, maybe you can get away.
Okay, I think we have exceeded.
anyone, last question.
Yeah.
Anyone looks for bicortical purchase in osteoporotic?
Yes, I try to do it.
Possible to do.
Completely do it.
I have, there is literature, ISIC also does it, but I haven't done it so far.
I have tried
It's
it
very
a couple,
risky,
but
but I
then you
tried.
can't. But then you can't do cemented screws.
No,
Yeah,
no,
You
for
have to
sure
use
not.
normal screws.
Yeah, absolutely.
All right. Thank you very
Also,
much.
one more thing while we're at it, one last thing, because some or the other, the industry tries to sell us these dual thread screws, but I'm again not happy with them because I don't understand how a screw can have a different pitch at two different areas, because a screw moves forward based on the pitch. So then, one is double, one is half. So how does the screw actually move? So I don't use these dual thread screws either. I think some of these, because the other problem which happens is then that screw ka front ka thing is the pitch is hardly anything. Like there's one particular company which has dual thread and normal screws. I think the normal screws have a much better sort of pitch diameter than the dual thread ones. So
Sir, I used to use them, but I stopped using them because I found there's a problem. When you put a dual thread screw, and for whatever reason, if you have to remove it, and then you will have to go one size higher because
time
if you remove that, it leaves back a big hollow over there. So I've stopped using them.
I like to use it for some reason. I feel that it is a little bit stronger. I don't know. I have no way
I
of
am
measuring.
exclusively dual thread screws.
I like them. Yeah.
But
Manisha,
whatever, you see, those who know me and all of you will do is know that I do new things only 2 to 3 years minimum after others are doing them. So I'm never the first guy out there. Anyway.
Thank you very much. Thank you to all the panelists for joining. I think we are well within time, not exceeded by only 15 minutes.
Yeah.
And thank you very much for joining and contributing. So we'll end the session here.
Thanks, Kshitij. Thanks, WIROC.
Thank
And
you.
the aim of this, guys, is for
Thank you,
everyone
sir,
to
and Kshitij,
register for
everyone.
WIROC. All the
WIROC.
listeners, please register for WIROC. Audience
Please.
members.
Yes. I'm sorry to introduce you as just Vice President of BSS. You are double Vice President.
I'm Vice President of BOS. Yeah.
And BSS also. Double. That's what I said.
I know. I'm doubly wise.
Doubly wise.
Okay, bye. Bye, guys.
All right. Thank you, everyone. Thank you.
Thank you.
Thank you, Dr. Kshitij.